Good morning to all. On behalf of TNOA, I welcome all the officers of TNOA, Dr. Atik, Dr. Sirram, Dr. Jayantan, and Dr. Nirmal, and all the Balaji and other office bearers. And of course, I have to thank and extend a warm welcome to all the panelists and the speakers and the moderator of this session for this webinar on optic disc A to Z. All of you know very well that blindness and visual impairment is one of the important public health problem all over the world. And keeping this mind, the International Agency for the Prevention of Blindness and other voluntary organization in the year 2020, in the year 2000, they have decided to have a World Sight Day in the second week, that is second Thursday of every year, that's in the month of October. So in that way, it's all over the world, this second Thursday of October is coined as World Sight Day, and throughout the world, the various activities are going on to promote the awareness about the blindness and visual impairment, and also its impact on the socio-economic conditions of each and every country. So for that, various other remedial measures have been taken just to improve the facilities and human resources and other things, so that people can get or they can go for ocular treatment without any hesitation, because most of the places the availability is one of the important thing. So how to make it so affordable and easily accessible, that's the one of the main motto of this day. That's the World Sight Day. So on this day, various awareness activities are also going on throughout the world. So keeping this mind, we have TNOA and Aravind Hospital Tirunelveli decided to have some sort of important webinar, especially which will useful to all the sorts of people like postgraduates, fellows, and also for the practicing ophthalmologists, because optic nerve is one of the important cranial nerve as far as ophthalmology is concerned, which is responsible for the conduction of the impulses from retina to the brain. So that's very, very important. And the optic disc, whoever come to our hospital, we as a part of our routine examination, we used to see the retina, mainly the optic disc. So of course, it is eye, they used to say, eye is the window of the human body. Similarly, our fundus, optic disc is the main thing that we do in our day-to-day examination. So in that way, we thought, why can't we have an exclusive webinar for optic disc alone? So Dr. Batmavati, our moderator of the session, she took up this and she made it this wonderful webinar with various topics in the optic disc. And also she has included the wonderful faculty in this webinar from across our state in various who are all doing wonderful work in the field of neuro-ophthalmology, glaucoma, and retina and VR, something like that. So including Dr. Makesh, Manju Pillai, and all the Dr. Vijayanand, Dr. Vanila, so many people. And also the panelists for this session also, as all of you know very well, Dr. Makesh Sharma, who is one of the very authoritative in the post-segment disease from Shankara, Bangalore, has immediately consented to be one of the panelists for this wonderful session, along with Dr. Manju, who is again one of the international figure in Movia, and Dr. Manju Pillai, and also Dr. Batmavati, and all other people as the panelists. And of course, I have to be very, very thankful to the moderator of this session, especially Dr. Batmavati, who is instrumental in bringing this webinar, and also Dr. Madhavi, who is a glaucoma consultant at Aravind Hospital, has done a wonderful work, and along with our ARC chairman, Dr. Atik, is also very much helpful in formulating this webinar. So definitely this webinar will be a useful thing to know more about the insight into the optic disease of various etiology, whether it's a glaucoma, or neuro-ophthalmology, or any other retinal disease, or inflammatory disease. Definitely is going to help in so many ways. That way I'm very happy, and once again I welcome all the panelists and the speaker and also the moderator of the session. And our president-elect, Dr. Nirmal, has joined. So I request Dr. Nirmal to say a few words on this conference, World Sight today. Dr. Nirmal, yes.
Yeah, thank you, sir.
Thank you.
Thank you, President. Thank you all the panelists and faculty for joining us for this important session. This is indeed a wonderful topic, often not heard or presented in many of our regular conferences. So this will be a useful resource material as well as a deliberation for the TNOA faculty. I'm sure World Sight Day, this webinar would be a useful one for this World Sight Day celebration also. So thank you so much, President, and all the faculty. Wish the webinar a success. Thank you.
Good morning. A warm welcome to this webinar on A to Z of the optic disc. I'd like, at the outset, I would like to thank my mentor, my guru, Dr. Akesa, for giving me this opportunity in leading the show. This topic, though it has been taken many times, but it is always a new enigma for all the postgraduates and consultants at times. So we thought we could include all the faculties from all the sessions so that we could have a proper guidance and knowledge disseminated. I think Sir has introduced Dr. Atik Sheikh, who's the chairman of the ARC-TNOA, who's with me as a moderator. Dr. Madhavi, who's a consultant at Aravind Eye Hospital, Tirunelveli, as the moderator. With that, I would like to introduce Dr. S.R. Ratna Madam, who is the Chief of Uveitis Service at Aravind Eye Hospital, Madurai. Her basic epidemiological and clinical research over 30 years at Uveitis Eye Clinic has uncovered the cause and source on pathogenesis for many outbreaks, which includes ocular leptospirosis, rheumatoid eye disease, and West Nile infection. So she has made outstanding contributions to ophthalmic literature, both international and international arena. She is an elected member of the International Uveitis Society. I welcome you, Madam, as a panelist. The next person is the eminent Dr. Mahesh Shanmugam, who is a retina consultant at Shankaraya Hospitals, India, at Bangalore. He is also the scientific committee convener, VRSI. He is also many awards, which I don't have time to describe in this session. He has many presentations in international as well as national conferences. He has also conducted many instruction courses. Dr. Mahesh Shanmugam, welcome on board. Dr. Manju Pillai, she is a glaucoma consultant at Aravind Eye Hospital, Madurai. She has been actively involved in patient care, training and teaching of postgraduates and ophthalmologists in the Society of Glaucoma. She has authored many book chapters and published many articles in national as well as international journals. Welcome on board. And with me, we have one more panelist, Dr. Ravi Shankar, who's an ophthalmologist at Rajan Eye Care Center. He's a member of the Indian Medical Association. I welcome you on board, Dr. Ravi Shankar. Moving on to the first speaker, that is Dr. Mahesh Kumar. He is the Chief of Neuro-Ophthalmic Services at Aravind Eye Hospital, Madurai. He has more than 20 years of experience in the field of neuro-ophthalmology. He has edited neuro-ophthalmology textbook for postgraduate students and also is the co-author of the Atlas of Imaging in Neuro-Ophthalmology. He is an invited speaker in various state, national, as well as international settings. Okay, over to you, Dr. Mahesh Kumar, for speaking on congenital anomalies of the optic disc.
Good morning to one and all. At the outset, I would like to thank Dr. Padmavati, the coordinator of this meeting, Dr. R.K. sir, and the TNOA for having invited me here. It's a great privilege and honor. So the topic given to me is congenital anomalies of the optic disc. So I'll be speaking this topic roughly on the following outline. First, I'll be discussing about the hypoplastic disc. Then I'll be discussing about anomalous disc excavations. In the anomalous disc excavation, we'll be seeing disc colobomas, morning glory syndromes, and optic disc pits. Then I'll be talking about anomalous disc elevations with drusen and without drusen. So we'll start with the case presentation. A 6-year-old boy with defect vision right eye was noted by the parents during a routine school examination. The visual acuity in the right eye was 6/60 with a relative afferent pupillary defect. So this was a fundus picture. So you can see a small disc and with a double ring sign, what we call it as a double ring sign. We'll see what it is. And this is the normal side of the normal optic disc on the other side. So basically, optic disc hypoplasia is a small optic nerve head, and it occupies a fraction of the usual disc area. It is surrounded by a pale or a pigmented halo of sclera between the margin of the optic disc, optic nerve head, and the border of the retinal pigment epithelium. And this inner border is the present border of the optic nerve head, and the outer border represents the border of the retinal pigment epithelium and the choroid. So histologically speaking, there are two borders. If you see correspondingly to the inner border, we have this outer ring corresponds to the area where the normal optic nerve head should have been, but it has stopped short here. And in between, there is a, from this point, from the outer ring to the inner ring, there is a normal retina as well as the retinal pigment epithelium. This corresponds to the inner ring. The outer ring corresponds to the junction of the lamina cribrosa here and the sclera here. So that is why we get two rings where this optic nerve head is deficient. On the neuroimaging, we can see a small sized optic nerve. Normally, we see an optic nerve which is thinned out in case of optic atrophy, surrounded by CSF. In this case of optic nerve hypoplasia, the entire optic nerve sheath complex is thinned out, and that is one important differentiating feature to differentiate between acquired optic atrophy and a congenital optic nerve hypoplasia. So the clinical features may range from no light perception to a normal visual acuity. So the most important point to remember are, if it is an unilateral, it can have amblyopia, and it's important to correct the amblyopia. Bilateral defects will present much early because of poor vision in both eyes and nystagmus. There can be variable field defects associated, and there is a strong association of astigmatism. And so this astigmatism has to be corrected in these unilateral cases, especially to prevent amblyopia. But that is not the end of the story. So we should not stop with the eye. All these midline anomalies, all these congenital anomalies are associated with systemic associations. So the most important association described in hypoplasia is septo-optic dysplasia. What we call as septo-optic dysplasia is optic nerve hypoplasia, absence of septum pellucidum, and more importantly, pituitary dwarfism. So we can see here there is an absence of a septum pellucidum, and there is a pituitary hypopituitarism, and there are varieties of hormone deficiencies like growth hormone, hypothyroidism, hypocortisolism, and diabetes insipidus. And it's important and pertinent to refer these patients to the endocrinologist to have a complete systemic evaluation. There can be associated skull-based defects like basal encephalocele, other midline defects. And this is one other abnormality associated with the hypoplasia, which is called as a ectopic posterior pituitary. You can see a high riding posterior pituitary causing diabetes insipidus. So normally this bright signal is seen somewhere here, posterior to this. This bright signal of the posterior pituitary is shifted way above the infundibulum. So that's about the optic hypoplastic disc. Then we'll see about anomalous disc excavations like coloboma, glories, morning glory, and optic disc pit. So optic disc coloboma is a developmental abnormality where there is a failure of the fusion of the embryonic fissure, and it may be associated with a variety of other closure defects like iris colobomas retinal colobomas, optic nerve head colobomas, and choroidal colobomas are a combination of all these things. So typically these optic nerve heads appear larger. They resemble glaucoma, and the differentiating feature is these optic nerve heads are very larger as compared to the normal optic nerve heads. And in some instances, it can be associated with a variety of other colobomas, and carefully seeing an indirect ophthalmoscopy of other peripheral retinal colobomas will give us a clue to the diagnosis of optic nerve head colobomas. But that's not the end of the story. We don't stop with that. As discussed already, these are associated with endocrine symptoms, and the most common symptom, syndrome associated with this is a papillorenal syndrome associated with coloboma. It's not common, but we should not miss such cases. It is associated with renal hypoplasia. So any optic disc coloboma should be evaluated for renal dysfunctions and vice versa, which is associated with the mutation. And the differential diagnosis for this is a morning glory syndrome, which we'll see subsequently, and of course glaucomatous cupping, which we saw previously. And the differentiating feature will be a large optic nerve head size as compared to the glaucoma, where only the cup is larger. So next we'll see about abnormal excavation, morning glory syndrome. And morning glory syndrome typically is a large excavation of the posterior retina, posterior pole, in which the excavation of the optic nerve head is a part of it. You can see the excavation is not confined to the disc, but also in the posterior pole. There is some amount of glial tissue over the center of the disc, and there is difficulty in differentiation between arteries and veins in the optic morning glory syndrome. And the name given to it is because it resembles the morning glory flower, which there's a striking resemblance to it. That is why it is given that name. Again, the visual acuity may range from no light perception to 6/6, and functional amblyopia is a common cause of visual loss in unilateral cases. So it's important to correct the amblyopia. So again, as in other cases, endocrine assessment should be done. And in this situation, the most common condition which is associated with the transsphenoidal encephaloceles, which is a defect through the sphenoid sinus, where the pituitary hypothalamus could be seen herniating below, and it can lead to a variety of hormone deficiencies like ADH deficiency, growth hormone deficiencies. So the next case is a 30-year-old male presented for routine eye examination. The visual acuity is 6/6 both ways, which are enlarged blind spot. So this is the fundus examination. There is an apparent disc elevation. However, on careful viewing, you can see some amount of calcific spots here, which are highly suggestive of drusen. So this is one important congenital anomaly, and it's important because we need to differentiate it from a true papilledema. The way to differentiate it from a papilledema is, so in the previous case, we had definitely exposed optic nerve head drusen, whereas in this case, we don't have an exposed drusen, but there is an elevated disc. So especially for the postgraduates, how do you differentiate the two? You see at the edge of the disc. Here, this is a true papilledema. And at the end of the disc, the vessels are seen coursing over the edge of the disc, and they are getting obscured because this elevation is due to nerve fiber layer edema, whereas this elevation is not due to edema, but there is something pushing the disc from below. And so all the vessels are also traversing above the elevation, whereas here the vessels will be obscured at the nerve fiber layer edema, and that's its one important differentiating features. And these drusen can have some infranasal field defects, and it can be familial, so it's important to examine the siblings also. And the imaging features, Dr. Padmavati will be discussing about the optic nerve drusen. So there are other differentiating features, differential diagnosis like myelinated nerve fibers, glial veil, and hyperopic disc, which hypoplasia, which can resemble an optic nerve head drusen. So wrapping up, there are other innocuous congenital optic disc anomalies like melanocytoma of the optic nerve head. It's important that we differentiate this from a melanoma by serial imaging and ultrasound and careful follow-up, and as well as other anomalies like optic nerve head pit, which are mostly benign, but occasionally it can give rise to retinal detachments. So in summary, congenital optic disc anomalies are not something to be just not something just to be admired at. We need to go deeper into it. We need to have a detailed systemic evaluation, and unilateral cases, visual rehabilitation, prevention of amblyopia is mandatory. Thank you for your time, kind attention.
Thank you, Dr. Mahesh Kumar. Though the topic, it is a very vague, very well covered. There is a question for you in the chat box actually. What is the incidence of disc hypoplasia? How do you how can it be mistaken for a glaucomatous optic cupping?
Okay, thank you for the question. So disc hypoplasia is not uncommon, and usually it is not mistaken for a glaucomatous cupping. Morning glory may be mistaken for a, or a coloboma may be mistaken for a glaucomatous cupping, whereas optic nerve hypoplasia is usually mistaken for a congenital optic atrophy. So that is what it is usually mistaken for, and the key differentiating feature is the double ring sign. So of late there is increased incidence of reporting of optic nerve hypoplasia, predominantly because of increased recognition. And not only that, because of other environmental factors, it is being reported to be increasing in incidence nowadays.
Okay, thank you, Mahesh. What about, will you include a tilted disc syndrome in a congenital disc anomaly?
Yes. I apologize for overlooking it.
No, I just remembered it. I'm sorry about it.
Yeah. Somehow I overlooked it. And tilted disc is an important differential diagnosis, especially in myopias and congenital tilted disc. It's an important congenital optic disc anomaly.
Okay. Any other
Mahesh,
questions?
wonderful talk, Mahesh. This is Sriram.
Yes, Sriram. Thank you.
Ma'am, thank you. That was a question going through my mind, the Conus syndrome. Mahesh, any tips on how to differentiate a Conus syndrome from a hypoplastic disc? Because both of them will have a small area of exposed sclera. And the disc, there'll be a double ring sign.
It's only when you keep seeing cases, we can sometimes pick up
I don't have a real answer.
Because both are looking like it's very easy to get confused between these two: a tilted disc, Conus syndrome, and a hypoplastic disc. And both can be unilateral also.
Okay, so I'm
Maybe
not.
we'll ask RK sir or Mahesh sir for tips.
The panelists
can help us.
So how to differentiate a Conus syndrome from a hypoplastic disc?
Any idea from others?
Dr. Mahesh Shanmugam.
The conus will also have an associated area of triangular RP atrophy below that. Not RP atrophy, depigmentation of the RP. So the rest of the RP will look a little darker, but inferiorly, down towards the conus, you will see an area, a well-defined area of RP color will be different. It will be a little bit paler there. And the discs as such is tilted in the sense one border will be a little bit clear, the other border may not be clear. In the sense like it looks excavated, in contrast to hypoplastic disc where you will see the concentration.
Okay, thank you,
The
Dr. Mahesh.
OCT of the ONH be more helpful in those cases, sir? In any way.
So another thing, Mahesh, you told about the papillorenal syndrome, no? There's a coloboma with renal hypoplasia or something. How often? Because so far we have seen so many cases because glaucoma. No, many times we have seen coloboma of the disc treated as a glaucoma because they will show the typical arcuate visual field defect. So how often you will have you seen anything association with renal hypoplasia and coloboma of the disc?
We have not seen so far, sir. I'm not seen so far.
No, is it necessary to subject the patient for any imaging or anything? We have to refer the case for nephrologist for this.
Yes, sir. We should have a detailed renal evaluation, renal function test, and possibly ultrasound of the abdomen should be done. Okay. And these cases should be referred to the nephrologist for further evaluation.
Mahesh, any idea? Any coloboma with renal hypoplasia?
I haven't come across one of those.
Oh, okay.
Of course, like, we don't usually investigate them as well.
Okay.
So glaucoma to choroid with the optic disc, we do keep seeing routinely. We have not investigated.
Mm. Okay.
Okay, sir. Can we move on to the next topic, sir?
There are some questions in the chat box, madam. We'll take it later, madam.
Yeah, we'll take it later because at least we were running short of time. Maybe 1 or 2 questions relevant, then we can proceed. At the end of the discussion, maybe we can take up the. I would request Dr. Madhavi to introduce the next speaker.
So good morning all. So our next speaker is Dr. Neetu Mohan. Madam is the consultant and chief of glaucoma service at Aravind Eye Hospital, Chennai. She completed her undergraduation from the prestigious JIPMER and post-graduation from RIO. She has a vast experience from glaucoma from Aravind Eye Hospital, Madurai, and she is a good teacher and actively involved in teaching residents. She will be talking to us on optic nerve evaluation in glaucoma. Over to you, ma'am.
Thank you, Madhavi. Am I audible?
Yes, Neetu.
Yes, ma'am. Yes, ma'am.
Yes.
I thank Dr. Padmavati and RK sir for this opportunity to be part of the team today. So, coming to the topic, optic disc evaluation in glaucoma. So, as we know, the very definition of glaucoma is the characteristic change to the optic nerve head associated with visual field defects which correspond to this optic disc change. So every other investigation that we do, including intraocular pressures, OCTs, and visual fields, do not hold any value unless it is correlated with the disc findings, and hence the importance of disc evaluation in glaucoma. So when we do a disc evaluation, the aim is, of course, to detect glaucoma as early as this, at the point of an RNFL change happening. That is when we can detect glaucoma before a change in the visual field happens, early enough to cause functional disability to the patient. So, how many do we usually miss? How often do we detect glaucoma so early? So most population studies show a consistently high rate of undiagnosed glaucoma. A VIP study done in Melbourne showed almost half of all undiagnosed cases of glaucoma had visited an eye care professional, either an optometrist or an ophthalmologist in the previous year. So why does this happen? As we all know, the visible portion of the optic nerve is a highly variable structure. The disc size, the thickness of the neuroretinal rim, the presence of a peripapillary atrophy, all have a significant range of normality, and very often it is not that easy to determine whether a disc is normal or not. OCT, fundus photographs, and perimetry, of course, aid us in diagnosis, but essentially it always boils down to the clinical evaluation of the disc. So for the beginners, just to simplify disc evaluation, it is important to focus on 5 R's. First being the scleral ring. Second being the rim, the neuroretinal rim. Third, the retinal nerve fiber layer. Fourth, the region of peripapillary atrophy. And fifth, retinal and optic disc hemorrhages. So a step-by-step evaluation of the 5 R's can help us overlook some subtle findings during disc evaluation. So coming to the scleral ring, large discs tend to have larger cups and small discs are expected to have smaller cups. So a small 0.7 cupping in a smaller disc may be much more significant than a 0.75 cup in a larger disc. But it also matters that larger discs are also mechanically weak, and bowing of the lamina cuprosa in response to intraocular pressure may be more, and hence axonal damage may be earlier. The average disc size is 1,500 to 1,700 microns. And micropapillae is when the disc is smaller than 1.1 millimeter, and megalopapillae are larger than 2.1 millimeters. So normally the shape is slightly vertically oval with the vertical diameter larger than the horizontal. The maximal disc diameter is almost always vertical. An abnormal optic disc shape should always alert, just as Mahir sir has discussed earlier. An abnormal optic disc shape should always alert regarding the possibility of a corneal astigmatism. And also many of these abnormally disc shapes and tilted discs have visual field defects which can mimic an inferior arcade scotoma or even an hemianopia. This size asymmetry is much more common than we anticipate. It is as common as 1 in 7 patients. One of the commonest reasons for referrals to glaucoma clinic as a glaucoma suspect is disc size asymmetry. I would suggest that anytime you see a CDR asymmetry which does not have a focal rim thinning or an RNFL loss and normal IOP, it is always wise to go back and compare the disc sizes, because a disc size is not something that we register as part of a routine clinical examination. Disc size asymmetry is one of the common causes for labeling a patient as a glaucoma suspect. Focal rim thinning and sloping is part of the neuroretinal rim evaluation. And this is more significant when the changes are in the superior and inferior bones. As you can see, there is inferior and superior rim thinning associated with a characteristic wedge-shaped RNFL defect in this patient, which is pathognomonic of glaucoma. Cup disc ratio. Again, just to explain the concept to the beginners, the cup disc ratio is the diameter of the cup expressed as a fraction of the diameter of the disc. So if you divide the disc into 10 parts, how many portions of this is the cup taking up? So in this case, this will be a cup disc ratio of 0.4. So why do we depend on a ratio rather than an absolute number to describe the cup and the disc? So the concept of a ratio works because it is independent of the magnification by the optic media of the eye and of the lens that you're using or the fundus camera that you may be using. It is also independent of the size of the optic cup. Concentric cupping more than 0.7 should alert regarding the suspicion of glaucoma, and an asymmetry of more than 0.2 again should alert regarding a suspicion of glaucoma. ISNT rule is another marker for early glaucoma. So the NRR thickness normally is thickest in the inferior quadrant, followed by the superior, nasal, and temporal. This can be violated in early glaucoma. Again, as you move towards more advanced glaucomas, this concept does not hold true. ISNT rule will definitely be violated or may not be violated in advanced glaucomas, but in early glaucomas, when you want to compare normal to an eye with early glaucoma, violation of ISNT rule may be a useful tool. So here, as you can see in this picture, if you compare the superior disc, which is normal, and the inferior one, the inferior rim is much thinner than the superior here, and also associated with the diffuse RNFL defect. Just like the inferior rim is always thicker, the inferior RNFL is also the brightest when compared to the superior. Bioneting sign. So bioneting sign is traditionally described as a vessel when it climbs over a deep cup. What is expected is that it disappears for a short while as it climbs over a steep curve. And this is traditionally compared to the image of a bayonet. So it takes a bit of imagination since we are not very used to seeing bayonets. But this is, again, one of the classical signs of glaucoma, not pathognomonic. But when associated with a corresponding RNFL defect, it can be pathognomonic of glaucoma. Retinal nerve fiber layer defects are one of the key points to help an early diagnosis of glaucoma. Since these precede the development of optic disc and visual field changes, and it is always pathognomonic of a pathology, whether it is glaucoma or a compressive optic neuropathy or a BRVO or just a PRP. We know that there is something which has caused a ganglion cell loss when you see a retinal nerve fiber layer defect. We should make it a practice to look at it during every routine ophthalmoscopy so that you have a habit of looking at it, and even subtle defects will be picked up as you get used to looking at it. And the visibility of the RNFL, of course, decreases with age, but in Indian eyes, it is still very well visualized, even in elderly patients. We have the advantage of having a densely pigmented retinal epithelium. So we are, compared to Caucasian eyes, in Indian eyes, RNFL defects are quite easily picked up. So to look at the retinal nerve fiber layer defect, it is ideal to have the slit lamp light source at 60 degrees. As you can see here, these bright striations that you're seeing inferiorly and superiorly, the inferior arcuate and the superior arcuate bundles are the brightest. This is the papillomacular bundle, which of course will not be as light as the superior and the inferior arcuate bundles. But the arcuate fibers are very well defined even without a red free filter when the light source is at 90 degrees and you have a diffusely illuminated fundus image. This is again a patient who is suspected of glaucoma, And we are looking at the retinal nerve fiber layer with the illumination at 60 degrees. And with here you can see that probably there is something suspicious here. These are bright striations, as you can see, superiorly and inferiorly. And here alone, you see a small dark area here. And once you put the red filter, you can clearly see a good, very well-defined slit defect here. So slit defects are very easily picked up since they are very well defined, and it is good to pick them up early on since we'll be able to detect glaucoma at a stage where the visual field defects have not even happened. Wedge defects, when associated with focal rim loss, you will see large wedge defects like this as in this patient. And these are diffuse RNFL defects, which may be a little tricky to pick up, especially in a tessellated fundus as like this. So this is a highly tessellated fundus, and an inferior RNFL diffuse defect may not be as markedly, as easily seen as a wedge or a slit defect. But if you, in the red free, if you see the superior and inferior and compare, you can definitely see that the inferior RNFL is less well defined when compared to the superior RNFL, which is normally not the case. This is again a highly tessellated fundus with a diffuse inferior RNFL defect. If you compare the superior, you can see these bright striations here, which is missing inferiorly, and it is associated with a diffuse neuroretinal rim loss inferiorly, which is pathognomonic of glaucoma. This is the normal inferior RNFL. When you compare the two, you can see the difference. So region of peripapillary atrophy, though pathognomonic, but still they are not definitely pathognomonic of glaucoma, but still it is good to look at them since they have a higher association with glaucoma, especially the beta zone. The alpha zone is the outer area of peripapillary atrophy, which is actually an area of retinal pigment epithelial changes, and it shows up as a relective scotoma in our visual. Beta zone, which is more associated with glaucoma, is an area of chorioretinal atrophy with a complete loss of retinal pigment epithelium cells and markedly diminished count of retinal photoreceptors. This shows up as an absolute scotoma in visual fields. Retinal and optic disc hemorrhages are splinter-shaped or flame-shaped hemorrhages at the border of the optic disc. These are very rarely found in normal eyes, and 4 to 7% of eyes with glaucoma tend to have these optic disc hemorrhages. The frequency increases in early stage glaucoma to medium to advanced stage, and it is very rare in very advanced glaucomas. These localized RNFL defects are often found in 6 to 8 weeks. They evolve into an RNFL defect. As you can see here, there is an optic disc hemorrhage here, and there is an evolving RNFL defect below that associated with the focal inferior rim loss. So these optic disc hemorrhages may be a risk factor for a faster rate of glaucoma progression, not necessarily always related to IOP control, but it definitely indicates that there is some pathology which is progressing there. It is also associated with a 6-fold increase in the developing of primary open-angle glaucoma into an ocular hypertension, and is also more commonly found in normal tension. Classically, traditionally, the discs are described into different categories. Some are focal ischemic discs, which are associated with high IOPs, and there is a focal rim loss and an RNFL defect. And these kind of discs have an early threat to fixation. They can be more visually disabilitating than concentric couplings. Myopic discs are tilted, shallow, with a temporal presence of peripapillary atrophy with features of glaucoma. These are usually highly tessellated fundus, and the visualization of RNFL defected is very difficult in these eyes. And since these are also quite anomalous, OCTs are also not very easily done in these eyes. Sclerotic discs are shallow with saucerized cup and gently sloping NRR, peripapillary atrophy, and a peripheral visual field loss. These are common in older patients. Concentrically enlarged discs, these have uniform NRR thinning and are associated with a peripheral field loss. These are again associated with very high intraocular pressures. Just going through some case scenarios. This is a patient who was referred for disc evaluation on routine screening. The right eye was normal. The left eye, the disc photograph looks almost normal here, but the red-free photograph showed a suspicious diffuse RNFL loss inferiorly, and hence this patient was subjected to baseline investigations for glaucoma. And the OCT again in the corresponding area showed an RNFL thinning, and the and the perimetry showed a corresponding change in the visual fields. So this patient was diagnosed as a case of primary open angle glaucoma in the left eye. This again is a typical superior rim loss with a wedge RNFL defect. The inferior RNFL is absolutely healthy and shiny, and there is a superior RNFL wedge defect with the focal rim loss and a corresponding inferior arcuate scrotum on perimetry. This is a patient who's a glaucoma suspect who was on follow-up with us for many years. And she was normal, repeated fundus photographs and OCTs were normal. On one particular visit, the left eye showed a single RNFL defect in the inferior quadrant with a suspicious rim thinning inferiorly here. So we investigated further. The right eye was normal. The left eye showed a corresponding RNFL thinning on OCT. And the perimetry was normal. So we were happy we picked up glaucoma very early in this patient. But then the 10-2 did show a single spot here, a single point which was depressed. So which very often happens in RNFL defects which are very close to fixation, that the 10-2 sometimes picks up field defects which are usually missed on 24-2. It goes without saying that every clinical investigation has to be correlated. A change in the RNFL or the perimetry can be associated to any change which causes a ganglion cell loss, including a BRVO, PRP, or a compressive optic neuropathy. For the beginners, I would suggest to try this site, goneproject.com, which has a set of optic disc photographs, a lot of photographs where you can analyze each disc based on all these characteristics. There is a set of 15 discs which you can do a test on, and you can every parameter which has to be looked at is categorized, and you can say whether it's normal or abnormal, or whether it's a medium cup or a deep cup or a shallow cup, and everything can be analyzed, and then you get a reading based on how you have done in this test. So to summarize, always look at the 5 R's: the scleral ring, the neuroretinal rim, the retinal nerve fiber layer, the region of peripapillary atrophy, and retinal and optic disc hemorrhages. Always look at the retinal nerve fiber layer defects which are near the suspected focal rim loss. Wherever you suspect a focal rim loss, make it a habit to look at the corresponding retinal nerve fiber layer. Since changes to the retinal nerve fiber layer with a focal rim loss is pathognomonic of a pathology. Disc size asymmetry is much more common than we anticipate. ISNT rule is a good clue in early glaucoma. Carefully scan for disc hemorrhages. Fundus photographs are extremely good, not just for documentation, but also to pick up subtle disc hemorrhages and for following up myopic discs, which may not do well on OCT. And correlate always with OCT and perimetry. Thank you.
Thank you, ma'am, for the wonderful and crystal clear presentation. We have some questions in the chat box. So many a time we see retinal nerve fiber loss in red-free photo with normal IOP, neuroretinal rim, and visual fields. What would be the cause? I think madam essentially answered the question saying that RNFL loss will precede any optic disc changes. Ma'am, but I have an additional question to you. So if you are seeing only RNFL loss, the optic disc is essentially normal with an intraocular pressure in the normal limits, and any other investigations is also normal. So would you start your treatment?
First, as I had mentioned earlier, any RNFL loss does not always happen due to glaucoma. You have to rule out any other possibility or any other cause for an RNFL loss, an old BRVO or a PRP has been done, or the patient has had a transient spike in IOP earlier due to a trauma or steroid response or something which has been controlled in the past. If there is no other history which suggests, which we can point to, which has caused this RNFL loss, if this is the only, like if glaucoma, if you have ruled out all other possibilities, then the presence of a definite RNFL defect, we may have to consider him a glaucoma suspect. Whether I would start treatment with a unilateral RNFL loss without the disc changes, if there is no other cause for it, I'm not sure. I think I would discuss with the patient, say that you may be having early glaucoma. If you're willing to come for regular follow-up, 6 monthly OCTs and fields, you can do that. If not, we will start on treatment. Just based on an RNFL defect, I'm not sure. Maybe we can even try a DVT, diurnal variation, and do baseline investigations.
I totally agree with Neetu. I am Dr. Athinam.
Yes, madam.
Totally agree with Neetu. Post-febrile neuroretinitis also causes nerve fiber loss.
Yes, madam.
As you rightly mentioned, that cause also should be ruled out. It is very difficult to rule out, but because serology will not help. Only history of fever and defective vision in the past will help.
Yes, ma'am. Thank you, ma'am.
Okay,
Another question for the panelists. Ma'am, what is your approach to a tilted disc? Glaucoma suspect and tilted disc. What will be the approach?
See, again, we do all the baseline investigations to document the visual fields and the OCT, but very often tilted discs are also associated with myopia, so it's difficult to get a good quality OCT. We do try to do an OCT. If you get a good quality OCT, well and good. Otherwise, you will have to follow up the patient based on visual fields and fundus photographs. If the IOP is borderline and there is a visual field defect, it may be wise to start treatment. But IOP in low teens with a tilted disc and a visual field defect which corresponds to what you expect in a tilted disc, if the patient is willing to come for regular follow-up, it is wise to follow up based on serial baseline investigations, which is what I would suggest. RK sir, your thoughts on this?
Yeah, you are correct. Yeah, it's a tilted disc, always tilted disc as well as the myopia. Glaucoma in myopia is also one of the other challenging tasks for the glaucoma people. So sometimes it's very, very difficult to diagnose glaucoma in both these conditions. So you have to go with all other things like intraocular pressure, CCT, and visual fields, family history, and then only we can come to conclusion. Yes.
So my only point to add is that, like, whenever we examine the disc, it should be in a dilated fundus.
Yes, ma'am. Always.
Always.
Yes, ma'am. Thank you, ma'am. So for the introducing the next speaker, I invite Dr. Padmavati, ma'am. Over to you, ma'am.
Next, we have a young neuro-ophthalmologist who's from Dr. Vidya Dharini. She is a consultant in the Department of Neuro-Ophthalmology, Shankar Nethralaya. She'll be speaking on unilateral disc edema.
Thank you, ma'am, for the kind introduction. Thank you, ma'am. So I'll be talking about unilateral optic disc edema. To introduce, optic disc swelling is a clinical presentation of various life and sight-threatening conditions. It can occur because of various ocular conditions, intracranial lesions, or as a manifestation of various systemic diseases. Before I start the topic per se, a few differentiating points between true and pseudo-disc edema. In true disc edema, the patient is symptomatic, defective vision, color vision, or field defects. Not so in pseudo-disc edema. The disc elevation will be associated with peripapillary RNFL elevation in true disc edemas, but not so in pseudos. Only the disc elevation per se will be seen. Obliteration of cup is one common feature with both true and pseudo-disc edemas. Venous pulsations will definitely be absent in true disc edemas, but can be present in pseudo-disc edemas. Obscuration of vessels are definitely seen in true cases, but not so in pseudo-disc edema. But in certain disc anomalies, the arrangement of vessels can be different. Peripapillary changes such as hemorrhages, exudates are common in true disc edema, but not so pseudo cases. And on FFA, an early or a late leak can be present, but not so in pseudo disc edema. And in case of this optic nerve head bruisings, there will be autofluorescence. So another few examples of pseudo disc edema is a hypoplastic disc and a myopic tilted disc. So how do we go about assessing a patient with unilateral disc edema? A detailed history is mandatory. It gives us a major clue to what the patient is having. Clinic examination is basically the optic nerve function test, that is visual acuity, color vision, pupillary examination, assessment of the extraocular muscles, and a fundus examination. Tests like perimetry, DEP, neuroimaging, OCT and ultrasound, and blood investigations are important, and these are tailored based on the clinical presentations and the history. These are the various causes of unilateral disc edema I'll be talking about based on cases. So first is a 56-year-old male, a diabetic. He presented with sudden painless loss of vision in the right eye since 5 days. His vision was 3/60 in the right eye, RAPD was normal, and color vision was defective. The left eye was apparently normal. Right eye showed disc edema with pallor and few splinter hemorrhages. The left eye was a classically small, crowded disc, what we call disc at risk. He had in classical inferior altitude defect in the right eye, and HB of the left was normal. His HbA1c was elevated, so this patient had right anterior ischemic optic neuropathy. The next case is a 59-year-old male. He had visited us for the regular examination. He is a diabetic with dyslipidemia. His vision in the right eye was less since childhood, secondary to dense anisometropic amblyopia. Both the pupils are reacting well to light. There was no RAPD. In the left eye, vision was 6/6 and color vision was intact. This is the fundus photograph of the right eye. The media is because of cataract, but we can see disc appears to be normal. The left eye showed a disc edema with some amount of pallor and splinter hemorrhages. And his fields showed few paracentral depressed points. Left eye, he was not symptomatic. The pupillary reaction was normal. Color vision was intact. HVF only few paracentral depressed points. With this, we suspected him to have diabetic papillopathy. We had a close observation of the patient, and within few weeks, the disc edema had resolved. Next is a 61-year-old female who presents sudden but a painful loss of vision loss in the right eye since a week. Her vision was query perception of light in the right eye. Her extraocular movements were full but painful. This is the fundus photograph. Her disc edema in the right eye. Left eye was normal. HVF of the left eye showed few non-specific depressed points, but MRI showed a thickened right optic nerve sheath extending up to the optic canal with an hyperintense signal in the optic nerve. Optic neuritis was suspected, and these blood investigations were carried out, and patient had MOG positive antibodies. So in this case, the disc edema was because of optic neuritis, which was MOG associated. Moving on to my next case is a 60-year-old male who presented with gradual but painless diminution of vision in the left eye since 3 to 4 months. The known case of thyroid eye disease. The right eye was normal, left eye vision was defective, RAPD was present, and moderate dyschromatopsia was present. Patient had proptosis with all IOM limited. The right eye fundus was normal, but left eye showed disc edema. His HV of the left eye showed a 3-quadrant defect, and on MRI, there was thickening of all the left extraocular muscles with apical crowding. So this patient had a left active thyroid eye disease with this thyroid optic neuropathy. My next case is a 48-year-old female who presents gradual progressive diminution of vision in the left eye since 3 years. Right eye was normal, left eye vision was defective, RAPD was present with a defective color vision. The right eye fundus was normal as expected, but left eye showed disc edema. Again, her field also had a 3-quadrant defect. On MRI, there was gross thickening of the entire optic nerve sheath complex, but the optic nerve signals were normal. With this, we diagnosed her to have optic nerve sheath meningioma. Then this is a 27-year-old female who presented with subacute vision drop with mild discomfort in the left eye since 15 days. The left eye, the vision was defective. People were only sluggish reacting, and color vision was defective. Her right eye fundus was normal. Left eye again showed broad disc edema with hemorrhages and a complete macular fan. She had few depressed points, visual field defects in the left eye. Blood investigation, the monitor was positive, but others were within normal limits. Neuroimaging was also normal in this patient, so she was diagnosed to have neuroretinitis. Next is a 63-year-old male who presented with sudden painless loss of vision in the left eye since a month. He's a hypertensive. The right eye vision was normal. Left eye, he had no perception of light, and this was his fundus picture. With gross disc edema, hemorrhages, and cottonwool spots. So what are we dealing with? MRI showed a moderate thickening and enhancement of the left anterior optic nerve, and along with the thickening of the ocular cords too. What I didn't tell you all was he is diagnosed to have adenocarcinoma of the stomach with liver metastasis 5 months back. So this patient had a left infiltrative optic neuropathy. Moving on to my next case is a 58-year-old female who presented with painless diminution of vision in the left eye since 2 months. Right eye was normal. Left eye, there was moderate reduction in the visual acuity. RAPD was present with a mild dyschromatopsia. She also had few vitreous cells. Her right eye was normal, fundus. Left eye, again, shows a gross, angular-looking disc edema with multiple hemorrhages and hard exudates. In spite of such a dramatic-looking disc, there was only mild visual disturbances. She had peripheral constriction of fields in the left eye. Ultrasound picked up an optic nerve at elevation with a localized retinal detachment. MRI showed thickening of the left chorioretinal layer. With blood investigations, her Monton QTB was positive, but HRCT chest was normal. She was diagnosed to have optic nerve head granuloma. Moving on to the next case is a 38-year-old female. She had history of headache since a year and transient visual blurring of vision in the left eye since a month. She was on treatment for infertility. For ocular examination, vision, color vision, pupillary assessment, everything was normal. But fundus in the right eye showed a mild edema of the superior margin, and left eye showed early disc edema. Her fields were also normal. OCT showed a marginal elevation of RNFL thickenings. GCC was fairly good. MRI showed widened perioptic space, empty cellar, and the MRV was normal. So with the history of a long-standing headache and TVLs, we suspected papilledema, and we subjected her to LP, which turned out to show 35 centimeters of water. In this case, this is a patient with asymmetrical papilledema. My next case is a 57-year-old male who presented with redness, watering the left eye. His visual acuity was good. There was no RAPD. Color vision was intact, but he had cells in the anterior and the vitreous chamber. Fields were normal. This is the HVF. The fundus photograph. The right eye is normal, but left eye shows disc edema. With treatment with predpol and homite, the disc edema had resolved in 3 to 4 weeks. So in this case, the disc edema is of inflammatory disc edema. Next is we have a 20-year-old male. His secondary glaucoma was diagnosed elsewhere. He underwent trabeculectomy. His IOP in the left eye was only 2 mm. So on slit lamp examination, we had seen there was a thin cystic overfiltering blood, and it correspondingly had a disc edema in the left eye. Post flap desuturing, there was a gradual reduction in the disc edema. So this patient had disc edema in a hypotonous flow. My last case is a 62-year-old male, diabetic and hypertensive. He had blurring of vision in the left eye since 1 week. His visual acuity was good. There was no RAPD. Color vision was intact. So this case is in right eye fundus was normal, and left eye showed disc edema with dilate tortuous vessels and hemorrhages. In this patient had disc edema in the setting of a CRVO. To conclude, detailed history, comprehensive ocular examination is crucial. This helps us in ordering the relevant investigations, which in turn will definitely help us initiating treatment at the earliest. Thank you.
Thank you, Dr. Vidya. That was you had a very good case collection. I have a question to you. You had shown a case of optic disc granuloma.
Yes.
Was there any systemic condition associated with it?
Ma'am, she was only hypertensive, but she also had history of
because when you say a disc granuloma, a systemic association, you have to rule out, isn't it?
Yes, ma'am. We had evaluated sarcoidosis and tuberculosis also. And the QTB was positive. And therefore, she received IVMP under a cover of ATT also.
Okay, fine. And the next question is, you had shown a case of asymmetrical papilledema.
Yes, ma'am.
When you say an asymmetrical papilledema, it is bilateral. Maybe it would have been a subtle disc edema. But when you have an optic atrophy in one eye and you put a disc edema in the other eye, you could consider that as a unilateral disc edema.
Yes, ma'am. I could have put a pseudoposic NED or could have been posic NED. Yes.
Okay. Mahesh, any comments? Anyone on the panel, any comments?
I agree. Presentation, excellent case discussions.
Dr. Vidya, definitely a very good series of case presentation, and sincerely appreciate. I think all these cases can go into journals very easily. Sincerely appreciate that. For the benefit of the audience and benefit of private practitioners like me, I would like you to ask what are the systemic tests you to do? I mean the tests in the clinic and the tests outside the clinic. And in the clinic, what are the tests you would advise? Number two, outside the clinic, imaging, invasive, non-invasive. Can you just elaborate, please?
Okay, sir. So again, it based upon what is the etiology we are looking at. If it is an ischemic event, like an anterior ischemic optic neuropathy, in those cases, apart from the evaluation, we do a perimetry. Perimetry documentation, the perimetry is important. And blood parameters include ischemic workup. It includes complete hemogram. We look at the hemoglobin levels because anemia is a risk factor for NION. Then we should see blood sugar levels. HbA1c is mandatory. Along with that, lipid profile and serum homocysteine we include for all patients as a rule. And in certain patients with no history of diabetes or hypertension, and if you suspect a hemoglobinopathy, they are also referred to the hematologist to look into further any abnormal hemoglobin they have, they are assessed. This is what we do. If ischemic, we stop at that and then we try to control the risk factors. If you're suspecting an optic neuritis, if the patient presents for the first time with a unilateral involvement, we do the neuroimaging, preferably with contrast. And then apart from complete hemogram and to see the inflammatory levels, we do CRP, we do NMO and MOG the first time. If it is bilateral or if the age are extremes, younger child or an older patient, we do a workup for atypical workup. We rule out sarcoidosis, tuberculosis, ANCA-associated conditions apart from NMO and MOG. And in papilledema cases, if it is, we see whether it is IIH, that is when the MRI neuroimaging is normal. Along with that, we always include MRV because many patients with chronic venous sinus thrombosis do not have the dramatic symptoms of headache and nausea and vomiting. So we do a MRV for them. And if there is CVST, the patient refers to the neurologist where the opening pressure is documented so that cerebral antiedema drugs are also included apart from the anticoagulants. So in these patients, we really emphasize the importance of LP for manometry in these patients.
Thank you. Thank you so much for elaborately telling. Thank you.
Thank you.
A couple of very basic tests like color vision and the RAPD can differentiate a lot of these differential diagrams.
Yeah, definitely. What I would like to add is you categorize whether you have an optic nerve involvement or you don't have an optic nerve involvement. That itself can distinguish various causes, but always there is an overlap between papilledema and other conditions also. You can have a 6/6 optic neuritis or you can have a papilledema with vision loss. So it is always an overlap, but try to categorize with vision loss and without vision loss, then your diagnosis is a bit relatively easier. Mahesh Kumar, any comments? That, I think, yeah.
No more comments.
Okay, thank you. I think we'll move on to the next talk. I invite Dr. Madhavi to introduce the next speaker.
So our next speaker is Dr. Vijay Anand. He is the founder and chairman of Anand Eye Hospital, Madurai. He has worked as a previous consultant in Department of Shankar Nethralaya Neuro-Ophthalmology Department. He has multiple awards under his belt. We welcome you, sir. He will be talking on bilateral disc edema.
Okay, can you able to see my slides?
Yes, Vijay. Yes, you can proceed.
The first hurdle is clear.
Yeah. Yeah.
So it's a wonderful concept, lovely concept where we can see all the specialty get merged here. I would like to thank the team TNOA and Dr. Padma for giving me this opportunity. So next hurdle, I have to convince the people how to approach a patient with bilateral disc edema, what they are going to do. Okay, let's see within 2 minutes how I am going to convince the people. By looking at this type of disc swelling in our clinical practice, okay, one must be really puzzled. What could be the real etiology for this problem? Based on the disc swelling alone, it's very difficult to come to the conclusion what could be the cause. It's need a collective effort. As Dr. Shanmugam sir said, it's need proper history taking, assessing the optic nerve function test, treating people, vision, color vision, and fields. The color vision is a very simple and clinical tool in our office. It gives helps to differentiate different clinical conditions. Most of the time, we need some sort of investigation like neuroimaging, blood and CSF analysis, and blood pressure. It will help us to cleanse the diagnosis. Let's familiar with few terms. It will help to understand the clinical process. Pseudo-disc edema is a false disc edema where this looks like edematous but not. It's just elevated disc without axon swelling. And the two disc swelling due to any cause is called optic disc edema. The papilledema, the term should use only with bilateral disc swelling with rise ICP. You should not use the term for any other condition with bilateral disc swelling. If you confirm the patient has rise ICP, then you can use the term papilledema. The two important clinical questions we have to ask any patient with disc edema to cleanse the diet, to decode the patient with disc edema. Whether this disc is really swollen. So basically, you want to rule it from the pseudo disc edema. If swollen, how the optic nerve function is affected or not? Let's see. But true disc edema, then it could be some sort of optic neuropathy or papilledema. If not, pseudo disc edema is some sort of congenital anomaly like a disc drusen or elevated disc. Let's see a few clinical signs which help us to differentiate from the pseudo to true. So small curve, like a small curve, absent, small disc, absent curve, anomalous increase in blood vessels, and the vessels arising in the apex of the disc favor for pseudo disc edema. One might think this could be massively elevated disc, but if you see carefully, the surface of the disc, like here, you can see the disc vessels are clearly seen. There's no obscuration of the blood vessels. It's a favor for pseudo disc edema. In contrast, in the true disc edema, we see the vessels get obscured and see the cartels when hard oxidate and hemorrhages favor for pseudo true disc edema. So optic disc drusen is one of the common cause for pseudo disc edema. In this case, very obvious. You can see lumpy, bumpy appearance. So subtle cases, very subtle, where we cannot not able to pick up with clinically, then need some special ancillary investigation like autofluorescence. Ultrasound is very sensitive tool to pick up the patient with optic disc edema. Even with a low gain, we can see here there's a hyper reflective echo on the optic disc surface favored for disc drusen. CT scan also helps to hyper density echoes in the optic disc head. OCT is still evolving, and we may see hyporeflective space in patients with papilledema in the peripapillary region, where you can see this type of hyperreflective echoes in the peripapillary region. You can suspect disc drusen. Hyperopia and some disc melanocytoma, myelinated fibers may mimic like papilledema. One should be familiar with this condition. So as we discussed, small disc, absent curve, anomalous breaking of vessels, increased number of vessels, drusen, hemorrhages, and hard oxidates, and it will help us to differentiate from the true to disc. This is the first hurdle to make sure it's a true or false. If it is ruled out, if you make sure it's a true disc, then comes the optic nerve function, how the vision, color vision feels and people. Then if it is affected, then some sort of optic neuropathy. Bilateral disc swelling in young patient, that could be usually young patient, the inflammatory or infective condition can cause. Usually it will be a retrobulbar neuritis or iliac will be the most common causes. Bilateral, then you can suspect some type of atypical optic neuropathy like papillitis, like sarcoidosis, Lyme disease, like NMO could be caused bilateral disc swelling with profound optic nerve function dysfunction. Old age, anti-ischemic optic neuropathy can present with bilateral disc swelling. In the initial stage, the papilledema, the optic nerve functions are preserved. The chronic stage, where the axon is not able to withstand the pressure, it sets in optic atrophy, the optic nerve function get lost. So the patient with a normal optical function, we have to do the MRI to rule out any structural cerebral intra-space occupying lesions. If it is no, then we have to do the lumbar puncture to note down the CSF pressure to confirm the rise ICP. If the pressure is also normal, then we have to think about other causes like, see, we the ophthalmologists, we can do the real favor to the patient by checking the patient blood pressure. Any patient with a bilateral disc edema can save the life. Other causes like heart disease, sleep apnea, spinal cord tumors, we tend to search the lesion somewhere in the brain, but somewhere down, it's in the same compartment can raise the ICP. So you have to look for any spinal cord tumors. Uremia, hypoxemia, or anemia, a very profound low level of anemia can cause. bilateral disc edema without right ICP. We know that it's a bilateral disc swelling, but it can present asymmetrical presentation. One is mild to moderate or severe. We know this papilloma could be caused for rice ICP, hydrocephalus, meningitis, any venous sinus thrombosis, so any malformation. So the choice of investigation is MRI with the contrast, brain and orbit. MRI venogram also we should do. The role of MRI venogram we'll see in the subsequent slides. This one grading is very simple. Helps to grade the papilledema in our clinical practice. It goes from 0 to 5, so we can able to assess at the time of present what is the grade of papilledema, and also you can subsequent follow up. You can note it down how it is progressing, deteriorating or improving. Grade 0 is an absolutely normal optic disc. Grade 1, we can see this nasal C-shaped hollowness in the peripapillary region. Basically, you have to see the peripapillary nerve fiber layer and the blood vessel. These two things you have to see closely in our 90-day examination. Grade 1 is you can see the nasal side C-shaped peripapillary hollow without vessel obscuration. The temporal side is packed. Grade 2 is where you can see the complete 360-degree NFL prominence. Grade 3, along with the NFL prominence, we can see this type of vessel obscurations. That's favored for grade 3 in the margin of the disc. Grade 4, in the center itself, the vessel gets obscured. That means 4. The 5, all the entire optic capillaries, large vessels get obscured. So this goes from 0 to 5. Basically, we have to see the nerve fiber layer and vessel obscuration. The margin vessels get up to 3, 4, 5. Let's see a few case scenarios. Here is a 20 years old female patient presented with a headache, shoulder pain, transient visual obscuration, tinnitus, and her optic nerve functions are normal. So the symptoms favor for raised ICP, and clinically you can see there's a both eye disc elevated, maybe prison scale, maybe 4 to 5. So obviously we are suspecting some sort of a raised ICP. So the next logical step is to do the neuroimaging to rule out space occupation. This patient is MRI is normal, except she has a perioptic space widened and the empty cellular is favored for radiologically favored for raised ICP. Yes, we have to do to confirm LP to confirm the raised ICP. We have to just connect the spine needle with the manometer to see how much the CSF goes rise. Normal pressures 10 to 20 centimeters of water in patient with raised ICP go up to 65 centimeters of water. And also we can do the CSF analysis if we suspect any other pathology. It temporarily helps to relieve some sort of reduced ICP. In this patient, this ICP is elevated LP. So it will fix the criteria for a patient with the idiopathic hypertension, where the symptoms of right ICP, headache, tinnitus, transient visual obscuration, and clinically we have seen the papilledema, and MRI is normal except features of right ICP, and LP puncture showed elevated CSF. So patient with idiopathic hypertension, the treatment of choice in this mild to moderate cases, weight reduction and acetazolamide. Okay, weight reduction, we have to at least 20% of the weight reduction from the baseline. So within 6 months time, we can give oral acetazolamide 250 milligram 3 to 6 months time. In acute and fulminant cases, we can consider optic fenestration or LP shunt. In this case, the 3 months follow-up, you can see nicely this edema comes to operational 1 to 2. Before going to the subsequent, that the headache can present in most of the patients. That cannot take it as a sensitive symptom for the right ICP. But transient obscuration and tinnitus, one should ask if we suspect patient with papilledema, if we suspect a right ICP. Usually the transient obscuration, the graying of the vision. If it asks like how the graying of the light, like how current goes in this room, like the sun can ask the patient. Like TAA and amaurosis pugos, it will last only for a few seconds, like up to 30 seconds. Multiple episodes per day, up to 25, they have reported. And is reason for this optic nerve ischemia. Tinnitus also we had asked for. This is sound when you ask the history to the patient. They also see a single episode a day or two or multiple episodes a week. Then these are the very sensitive symptoms for a patient with a rise ICP. Here's another patient presented with history of fever 3-4 weeks before and presented a few days of intermittent diplopia with a headache. And when we asked about the tinnitus, he said some fullness in the right side ear. It's not other than anything. By examining the optical function normal, one could examine this casual examination. One would miss out this disc edema, where you can see the elevated nerve fiber. We can see the obscuration of the blood vessels, the right eye and the left eye. It's a grade 2 to 3 in present grading. So early edema. So obviously we have to do the MRI scan. The MRI contrast shows right side mastoid cell opacification, mastoiditis. Okay. We did the MRI venogram also. It showed the right transverse and the sigmoid sinus filling defects such as for thrombosis. This is the role of MRV. Unless we do MRV, this type of patient, we miss out sinus thrombosis. So role of treatment is completely different. We need antiheparin and coagulants plus antibiotics and anti-edema in this patient is responded well. So important to have MRV in patient with papilledema. So 6 now passes is the false localizing sign. So you look for ocular motility. In this patient, ocular motility was normal. When we did the cover test, he had a very small ET, like 4 base out in right gaze. So we had to do the most of the patients with the ocular motility normal. Unless you do the cover test, we tend to miss out 6 now parasis. Here is another young female patient. It's on antiretroviral therapy. HIV patient presented with headache and an examination. Patient had a papilledema, bilateral disc swelling. You carefully in the retina, we can see some little hemorrhages with the central white spots, the road spots. Okay, so we suspected some sort of infected endocarditis with meningitis. So we did the MRI is normal. CSF tap was absolutely the vital workup was normal. And further evaluation, the patient had a profound hemoglobin levels low. So basically, we know this idiopathic intestinal hypertension can be caused by secondary reasons like anemia, any chronic drug intake like tetracycline, vitamin A, oral contraceptive pills. In this patient, the idiopathic intestinal hypertension due to anemia, due to drug induced. So we reported this case idiopathic intestinal hypertension associated with anemia, secondary to antiretroviral drug in a hemodeficiency. So we need overall history taking and evaluating the patients very important.
Sorry to interrupt, sir. We are running short of time.
Maybe I'll just skip these 2 cases. Maybe if you want to take one message from this talk, then this could be this young patient presented with a headache, blurry vision, and the patient was suspected papillitis in the local place, treated with IV methylprednisolone and anti-edema measures. At the time of examination here, patient has a disc edema, peripapillary region has a hot oxidate and a cotton spots. So what would we like to do next? First is first. So simple clinical test. Any patient with papilledema, we have to check the without, we should not check the, we should not send the patient without checking the blood pressure. In this child is a 220, 120 in the high tachycardic, and further evaluation noted as suprarenal mass lesions, pheochromocytoma, the biopsy confirmed. So by checking the simple blood pressure, we can save the life. So the neuro-ophthalmic signs could be the good sensitive indicator for most of the neurological systemic diseases. So we ophthalmologists plays important role in the, picking up the diagnosis and follow up the patient. So one should have proper clinical knowledge to help the patient. Thank you for the opportunity.
Thank you, sir, for the wonderful presentation. Maybe because we are running short of time, we'll move on to the next presentation. Over to Dr. Padmavati ma'am for introducing the next speaker.
It gives me immense pleasure to introduce the next speaker, Dr. Parag Shah, who's a retina consultant at Arvind Eye Hospital, Coimbatore. His areas are main, he has developed the pediatric retina and ocular oncology service. He has well established the clinic, and his main areas of interest are retinopathy of prematurity, retinoblastoma, and intraocular tumors. He has many publications and presentations in this field. Over to you, Dr. Parag, for tumors of the optic nerve.
Thank you, ma'am. Is my screen visible?
Your
Yeah.
Oh.
No, not yet. Parag.
You are visible, Parag. Your screen is not visible.
Yeah.
Slides are not visible?
Slides are not
Illa.
visible.
Oh. So many publications, but don't know how to. Basics are always weak from the beginning.
You can take help from
That's why you should participate in more Zoom meetings for us. You're sticking to journals.
Now that you are talking, now it's come now. I can see your name. Great. Yeah, thanks. Yeah.
You only.
Thank you.
Yeah.
Right.
I guess you still need my touch.
Always from the PG days, you're always there to guide me. Okay. At the outset, I'd like to thank Dr. Padmavati, RK sir, and the TNOA Governing Council, my close friends, Dr. Sriram Gopal and Balaji, for giving me this opportunity, and Mahesh sir to being the panelist. And I'll be talking on the optic disc tumors. So it is actually quite a rare group of disorders, and you can classify it as primary, secondary. Primary is usually benign. Secondary is usually infiltrated from outside the eye. And there is a third category where a primary benign tumor can turn malignant. And the last is the chemotherapy drug induced, where the chemotherapy is given for some other cancer and it develops disc infiltration or a disc edema. So starting with primary, the benign tumors, the optic disc melanocytoma is the first one, which is the most commonly seen, which we see in a practice. Second is the combined hamartoma of the retina and the RPE. And thirdly, the vascular tumors. I'll be talking about a little bit on the capillary hemangioma, cavernous hemangioma, and the racemose hemangioma. Now, optic disc melanocytoma is a benign pigmented ocular tumor. It is usually asymptomatic. The patient has good vision and usually diagnosed on a routine examination. And it can be as subtle as this small grayish patch in the inferior of the disc, or it can be a large pigmented mass as seen here, which is extending into the surrounding choroids. It can be a retinal portion and the choroidal part, or it can be as large as this, which is covering the entire optic disc. Now, the retinal involvement usually has feathery margins, as you can see in this red-free photograph. And this is one of the hallmarks of a melanocytoma, the feathery margins. Other thing, the prominent intrinsic vasculature, subretinal fluid, and retinal exudation are absent. These should not be present. Usually, they are not present in a melanocytoma. And they can have pigment dispersion in the vitreous cavity, which is also not that rare. And it has been seen, and especially we have seen cases of ciliary body melanocytoma with pigment dispersion coming as secondary glaucoma. And that is also not a very rare thing to see. Management is nothing, just observation. You can just do a good fundus photograph, probably a baseline B scan, and FFA just to see the intrinsic circulation, but usually is not mandatory. And you can see it's all block fluorescence in these serial scan, and probably a OCT also, if it's available, you can do. And once in 6 months follow-up is what is required. Now, what are the features of transformation of this? Is one of the primary benign lesions which can turn malignant. First of all, it is extremely rare, and the things to remember is that there should be a documented growth, a profound drop in vision, and intrinsic circulation on the fundus fluorescent angiography, and the other signs of activity like subretinal fluid, exudation, and so these are some of the points that it may be going into a malignancy from a primary benign tumor. However, there is something called as a transient tumor necrosis, which can, or autonecrosis, ischemic necrosis, a melanocytoma can undergo, and they can present with a slight visual loss with mild retinal exudation beyond the fovea, and which usually settles up within a few weeks' time. And you can try a short course of steroids. We have tried a few anti-VEGF injections also, and they usually settle. However, if the visual round is profound with the documented growth, then you should suspect malignancy, do a systemic evaluation, and talk to the patient about the treatment options like enucleation. And like I said, malignant transformation is extremely rare, and it's reported in the literature only to 1 to 2% of the melanocytoma can turn malignant. Now, this is an interesting case which presented 2 weeks back. It's a 76-year-old male, old case of polypoidal choroidal vasculopathy, IPCV, was given anti-VEGF injections in 2009. Recently, he developed a vitreous hemorrhage for which pars plana vitrectomy was done elsewhere. And intraoperatively, mass was noticed on covering the optic nerve head and was referred here for further management. So this was the fundus picture of the left eye. So post vitrectomy, you can see a dark pigmented lesion. Disc cannot be seen. Fairly grayish lesion, and then there's a macular scar because of the old IPCV disease. We did a fundus fluorescence angiography and ICG, and no obvious intrinsic. There was a mild hyperfluorescence here, but it was not that significant to call this as an intrinsic circulation. B-scan showed uniform low internal reflectivity and giving this, a little bit of this cholesterol appearance, which was a little suspicious. So there was a documented vision loss, but then you can attribute it to the macular scar. There was no obvious intrinsic circulation, and there was no other signs of activity like exudation or subretinal fluid. But however, when we asked him to show us the previous pictures in 2009, so this was what the disc looked 2009. There was no pigmented mass lesions seen that time, and this was a fluorescent angiogram. So then this is obviously a documented growth now. So I was sent for systemic evaluation in his hometown, and they preferred to do a PET scan. And PET scan, although it showed the mass in the eye, it did not show any FDG dye uptake. And so there was no evidence of active disease that may suggest distant metastasis. Everything was normal. But like I said, like PET may be a gold standard for staging the disease, but we have seen that in a few cases that PET is not that significant to diagnose an intraocular choroidal melanoma, especially if they are metabolically a little less active in the Indian eyes. So what do we do next? So there is something which we'll be discussing with the patient, and I would like Dr. Mahesh later on to give his comments on how we would proceed. Would we go for a biopsy or enucleation? One 16-year-old male patient came with the clinic. This is another case with defective vision of 6-month duration. The VCVA was 6/36, grade 2 RAPD, and there was a disc edema and was referred to the neuro clinic for further management. However, a dialytic fundus examination showed this obviously pigmented mass lesion on superior to the disc with this POD orange pigmentation, and there was some subretinal fluid. Fundus autofluorescence showed the hyper autofluorescence of these pigments. B-scan showed a nice dome shaped mass lesion over the optic disc. And the OCT showed the dome shaped lesion with intraretinal spaces. And on the fovea, you can see this shaggy receptors. So this was a case of a suspected to be case of a melanoma, which was not on the optic disc, but was infiltrating the optic disc. And then we gave the treatment options of enucleation. And that is the best treatment option because you don't want to try brachytherapy, although you can do it, but so close to the optic nerve, I mean, it's not going to salvage the vision at all. And the patient went for enucleation, and the final pathology did turn out to be a parapapillary choroidal melanoma. I just wanted to share with you that if there are small ocular melanomas which are near the disc or near the macula, then there is this mnemonic which is developed by the Shields group called as the to find small ocular melanoma using helping hints daily. And it means that if the thickness is more than 2 millimeters, if there is subretinal fluid, symptoms, orange pigmentation, or the tumor is very close to the optic disc or ultrasound halowness, absence of halo, and the absence of drusen. So if you find any 3 or more of these characteristics, then you might say that this melanoma, small melanoma, is active and requires treatment, which usually we just do observation for that. And such close cases earlier during the collaborative ocular melanoma study, whichever tumor was very close to the optic, now they consider it as a large melanoma and enucleated because there were no notched plaques. Now we have notched plaques now, which we do for you can give brachytherapy. But the problem is that if it's so close to the optic now, the radiation is going to knock off the entire optic nerve and the fovea, and the visual outcome is going to be extremely poor. Coming to the next case, this was a 10-year-old female with a headache of since 1 week. She had vomiting 6 episodes 5 days back, history of fever and joint pains since 5 days. Not notice any defective vision or eye pain, but on examination here, the BCVA was 612 and left eye was 6.6, and this was the fundus picture seen where you can see whitish patches near the optic disc. And this was treated as suspected to be as a retinitis, and it was referred to the UVA clinic, and uveitic workup was done, and it all turned out to be normal. And we just did with a OCT, and OCT you can see obviously it's not a flat lesion, it's an elevated lesion, and the hallmark here is this basically the moth-eaten appearance. This is a case of a hamartoma, which was retinal hamartoma, which can be seen and which can be easily misdiagnosed, and OCT is a really helpful tool to pick this up. So it was a congenital lesion which was just by chance picked up during the examination. So the combined hamartoma of the retina and the RPE, these are the benign tumors. They're usually unilateral. It can be bilateral, and bilaterally is usually syndromic, and it can be it'll be outside the optic disc, the tuberous sclerosis, but it can be near the optic disc also. And you have to rule out tuberous sclerosis, and another thing is the neurofibromatosis type 2. And they usually come out with epiretinal membranes, and there's always a thing that should we peel or not to peel, do a vitrectomy. But obviously, I mean, surgery is not difficult, but the visual outcome is usually poor. But there have been reports now that doing vitrectomy is a little better in the long term for these cases. Come to the vascular tumors, the capillary hemangioma, the VHL syndrome, and usually it's in the periphery, and very seldom you can see it on the optic disc as shown here in these fundus pictures and on the ultrasound. And it's always a challenge to treat these cases when they're active at the optic disc. Peripheral lesions, you can do laser, cryo, and they do very well. But how do you treat these cases at the optic disc? So this was one case. This was a case given by Dr. George Monayat that was photodynamic therapy. This was an angioma which is very close to the optic disc, and he did a standard fluence photodynamic therapy, and it digressed quite well. And I mean, this was a little away from the optic disc, but I remember in one of the VRSI conferences, Dr. Sangeet Mittal had shown an extremely large angioma sitting over the disc. And because these are very vascular tumors and the blood flow is very high, so he modified the photodynamic therapy, where what he did that instead of giving for 10 minutes, he just gave the vertiforfin dry only for 5 minutes. And instead of waiting for another 5 minutes, if you start the laser at 15 minutes, he gave the laser early at 6 minutes. And instead of giving for 83 seconds, he increased the time, and he had also some fantastic result. So PDT is quite helpful, but unfortunately the dye is not available that freely as it was a few years back. Cavernous hemangioma, these are like grape-like structures, blood-filled saccular spaces usually, and they don't leak on the FFA, usually unilateral. This is a rare case of a bilateral cavernous hemangioma, which was published by the group from L.V. Prasad, Kalki et al. Racemose hemangioma, this was a 11-year-old girl which presented for in our clinic for a routine examination, and you can see this dilated tortuous vessels, AV malformations. And obviously you have to see the fundus periphery and make sure there are no sort of angiomas. So just to say that, I mean, it's not a VHL, but it's just a racemose angioma, and they are usually associated with the brain AV malformations, and a MRA of that patient revealed an AV malformation. It was diagnosed as the Wyburn-Mason syndrome. This was a 64-year-old male with defective vision of right eye, 1 year duration, and he was a known case of CA prostate 3 years back. And this is the disc, which is elevated, and a whitish mass lesion is seen here. And then if you see a fundus examination, there's a very subtle mass even around on the posterior pole. And when we examine the other eye, this eye also had a very subtle mass near the fovea. And so we did the ultrasound, and the right eye ultrasound and the left eye showed a flattish marsh with the variable internal reflectivity with exudate detachment in the right touch. This was a case of a choroidal Mets. And the choroidal Mets, I just want to, compare this to this analogy, given by Dr. David Abramson in 2006 when I was there. He compared this, choroidal metastasis to the peanut butter, the chunky style. You get this peanut butter with the crunchy or the chunky style where all the chunks of the peanuts are hidden inside. You don't see that. So metastasis is something like that. If you're suspecting metastasis, do a very meticulous examination in the same eye. And if you see a multifocal lesion or you see a focal lesion in the other eye, you are dealing most of the time, 99% of the time, with a metastasis. And these usually require, that's why they require a whole globe EBRT rather than brachytherapy, because even if you think it's an obvious single mass, there will be small masses hidden everywhere. And that is why a palliative EBRT is much better than a localized brachytherapy for these cases. Again, a case of metastasis, a 52-year-old female, diplopia 2 weeks. It was in 2022, presented with 2 weeks of diplopia was because of the bilateral 6-nerve palsy. The mastectomy, chemotherapy, and radiation was done in 2018. And this is the fundus picture of bilateral massive disc infiltration edema in both the eyes. So we just did a basic ultrasound and it was not that elevated, but what we could see is the crescent sign. You can see that there's a fluid around the optic disc. So it didn't look like these are the primary infiltration of the nerves. And we referred the patient for an MRI, and MRI showed that there is a leptomeningeal enhancement suggestive of brain metastasis and features of raised intraocular hypertension. So this was actually a papilledema. The patient presented with a brain metastasis because of the breast cancer. Again, a 72-year-old female presented with a sudden loss of vision after the 5th cycle of chemotherapy for CA breast, and this was active treatment going on with the paclitaxel and cyclophosphamide. And she presented with both eye, no perception of light, and the fundus revealed bilateral, hyperemic discs, elevated discs, and these bilateral hemorrhages, which you can see with a little bit of macular ischemia. So these are the side effects of the chemotherapy, the acute side effects which can happen with the paclitaxel and especially with the cyclophosphamide drug. This is a case of a hypopigmented lesion over the disc, the right eye. Obviously, this is a case of in a child for retinoblastoma. So this was the better eye, and you don't see the optic disc here. And then we gave systemic chemotherapy, and then now you can see the optic disc. So this was a tumor which was away, parapapillary, which is covering the optic disc. And after chemotherapy, there was a recurrence again, as you can see here. After chemotherapy and laser, there was recurrence. So what we did here was we did a ICG enhanced transpupillary thermotherapy, and after 2 cycles, that tumor also resolved very well. The last thing is the leukemia. Leukemia also can present with the first time to an ophthalmologist, and it can be a primary, a direct infiltration, which is a little rarer type, or the secondary indirect infiltration. I mean, because of the hematological abnormalities like anemia, thrombocytopenia, and you can see this large blood over the optic disc, near the optic disc. And these are the cases which are usually you have to do just a basic blood examination, and you can find and refer them to the hematologist, and these can be unilateral or bilateral. Even in cases where CML and ALL, we have seen cases where they're treated by the drug imaptinib, and this is a very commonly used drug. And we had a case of an imaptinib-induced optic disc edema. Usually it's a unilateral, but we had this 47-year-old male with a bilateral disc edema, which was more in the one eye and multiple superficial hemorrhages. Did a blood workup, and of course, he was a known case of CML. We talked to the oncologist. He said he's like in remission. Only this drug is going on. He's and well controlled. But then we found out, and we did our MRI, that most of the cranial nerves were enlarged, and this is a known side effect which can happen because of the imaptinib. So, in conclusion, like any case, the basic points are the history taking. Like, is the patient symptomatic, or did the patient come to you, or asymptomatic? Did you see a mass lesion? And is there any activity seen? On examination, you do a BCVA, a thorough fundus examination, take the help of imaging like fundus fluorescent angiography, the basic things. I mean, a fundus photo, B-scan, FFA-OCT, and probably systemic evaluation for suspecting a malignancy, and a baseline blood test. If you're suspecting something like a blood tumor, then just these HBT, CDC, ESR can really tell us that what we are dealing with, and it can really tell us that it can be something else and not the primary ocular lesion. So thank you very much.
Thank you, Dr. Parag. That was a wonderful lecture. I would like to invite Dr. Mahesh Shanmugam to give a comment on this session, because it's a bit intraocular tumors is a bit rare topic. So few experiences. We do had one case who had an infiltration with vision loss. I think Parag remembers that case, imatinib with disc edema. But many times we don't know how you can distinguish an optic neuropathy with whether papillary edema is associated, or is it an infiltrative optic neuropathy, or is it a drug-induced optic neuropathy. Always this confusion always arises in this scenario.
Yeah, thank you, Dr. Padmavati. Thanks, Dr. Parag, for a wonderful lecture and great collection of cases. Just a few comments. You did mention about the inflammation associated with the melanocytoma. So the inflammation can present as an optic neuritis or as a neuroretinitis. So that would be the time when the patient who has a melanocytoma can present to us with recent decrease in vision. So that can happen, and these patients that with steroids, the vision improves, and they will have an RAPD and decrease in vision, which resolves with steroids. And as far as the malignant transformation of the melanocytoma is concerned, one of the investigations which I do is the OPTA. So the melanocytoma doesn't show any intrinsic vasculature, but when it converts into intrinsic vasculature, but of course you can do an FFA as well. OPTA is a non-invasive test which can be done as well. And the case which you showed, the third case where the patient had undergone a vitrectomy, is probably a peripapillary choroidal nevus which the patient had, which grew into a mass over the optic nerve as a big melanoma subsequently. That's what it looked like. And you very rightly showed that the orange pigmentation is a distinguishing factor, and melanocytoma doesn't have any orange pigmentation, but when there is orange pigment on the tumor, it's usually a melanoma. And one other case, like the DD, the THRP, which you showed, the DD could be a retinocytoma. The whitish lesion, which is discovered incidentally, could also be a retinocytoma. And the disc angioma PDT, yes, the same technique which you do for choroidal hemangioma as well. So inject in a bolus and treat within 3 to 5 minutes, because the blood flow is so rapid between these tumors. You can treat these lesions with PDT with a different protocol. And optic disc metastasis, I've had one patient which caused central retinal artery and venous, combined arterial and venous occlusion. And one of the tumor which we can come across over the optic disc is the astrocytoma. So astrocytoma, mulberry-shaped astrocytomas can happen over the optic disc, which are usually associated with tuberous sclerosis, and they're asymptomatic. The other form of the giant astrocytoma, which can exude and patient can present with symptoms. Otherwise, the astrocytomas are usually diagnosed on protein examination in a child with tuberous. Once again, thank you for a great lecture, and thanks Dr. Padmavati for the invitation.
Thank you, Dr. Mahesh, for your comments. Next, we will move on to the next talk. Dr. Madhavi, to invite the next speaker.
The next talk is on disc in uveitis by Dr. C.G. Vanilla. Dr. C.G. Vanilla, Madam, is the Professor Consultant Retina and Uvea Services at Joseph Eye Hospital, Trichy. She is the head of Department of Paramedical Courses. She has won many awards, including the Gold Medal for Professor E.T. Selvam Award at TNOA 1998 and Professor C.P. Gupta Best Paper Award in TNOA 2012. We welcome you, ma'am. Over to you, ma'am, for the presentation.
Good morning. Am I audible?
Yes, ma'am. You are audible and your slides are visible.
Yeah.
Okay. At the outset, I'd like to thank Dr. Padmavati and RK sir for giving me this wonderful opportunity. I am privileged, sir. Thank you. I'll go to my slides. Is my slide visible?
Yes,
Yeah,
Vanilla.
yes, sir. You have to go to slide mode. Yeah.
Okay, thank you, sir. When Padmavati called me, I didn't know what to speak in uveitis and disc. So I thought I will just talk about the case scenarios which I had seen in uveitis with disc involvements. So as uveitis, all of you know, is inflammation of the uvea, which we always say with keratic precipitates, AC flare and cell circumcorneal congestions. So what about the disc? That is what I was wondering when Padmavati called me. So when we will get disc findings in uveitis, we'll get whenever there is posterior uveitis, retinal vasculitis, and pan uveitis. And what are the disc findings in uveitis? You'll have disc edema.
Vanilla, your slides are not moving.
Oh, sorry.
Screens,
You have to put it in a slideshow mode.
Yes, it is in view. What you are viewing, full screen you have to give.
Full screen.
What?
Full screen. Yes.
Yes. Stop sharing and then put it in the full screen mode and then share the whole thing.
Okay.
Vanilla, your slide is visible. You
Yeah.
can move.
Yes.
Inflammation of the uvea is uveitis. So when we'll have disc findings, we'll have when we have posterior uveitis, retinal vasculitis, and pan uveitis. The disc findings, what will be the disc findings? It will be disc edema, neovascularization and disc, or optic atrophy. So we'll be seeing one by one. Like the most common cause of posterior uveitis is toxoplasmosis. And in toxoplasmosis is a very classical. We'll have pigmented lesion and an active lesion adjacent to this. This patient presented with blurring of disc margin along with this retinochoroiditis findings. And with starting of the anti-toxoplasma therapy, the lesion started to heal. The first one to reduce was the disc swelling. So inflammatory disc edema along with this retinochoroiditis was seen. Next was this patient who had choroiditis with serious detachment around the disc, and so he's having blurring of disc margin, and he had choroidal patches around the macula. His FFA shows clinical hyperfluorescence in the early phase and hyperfluorescence in the late phases. This is another case of a 25-year-old male patient who came with multiple lesions around the posterior pole with swelling around the disc. This was a case of acute posterior multifocal pigmentoid epitheliopathy, and we again see the leakage from the disc, which is suggestive of the disc edema. He resolved spontaneously after 2 weeks. The next case, this case was a case of pan uveitis. The patient came with exudative detachment and bilateral disc edema, and he had ILM folds at the macula both ways, and on FFA he had pinpoint leaks around, and he had the leakage from both the discs, and pinpoint leaks which were pooling in the later stages were seen, classical for a BKH syndrome. This is mainly Harada's disease where you have pooling of the dye. Next case was a case of retinal vasculitis. This patient presented with a sequelae of vasculitis, and he had an NBD in the right eye and active perivascular cuffing in his left eye. On FFA, we could see the disc leak showing the NBD and a NBE in the right eye and perivascular cuffing, which showed the staining in the late staining of the disc. And he responded to steroids and he underwent laser PRP for the right eye. This case was a multifocal choroiditis with the disc peripapillary involvement and a scar near the macula. And his FFA shows disc findings of inflammatory leak with the block fluorescence because of the hemorrhage at the disc. He responded well to steroids alone. This patient was a 22-year-old lady who came to us redness and pain, and on T sign shows a T sign, and the fundus shows a hypertonic disc with disc edema, choroidal folds, and ILM folds. And she responded to systemic steroids. This was a case which was referred to a medicine professor, and he was on treatment for tuberculosis. He came with defective vision in the right eye. He had actually treated for tuberculous meningitis. But when he came to us, he had neuroretinitis-like picture. Then he had multiple lesions in the posterior pole, in the choroidal tubercles, and heel lesions in the nasal side, and active subretinal granuloma lesion at the choroid. And he was treated with ATT already started, but he was going on for around a year, after which the lesions were start healing. He was referred to a physician. This patient was on a heart therapy. He was a HIV positive male person, 34 years, and he came to us with defective vision in his eye, and we could see the typical brush fire-like appearance suggestive of CME retinitis, and because it is the peripapillary region, he had disc involvement also. He was on HIV heart therapy, and his CD4 counts, 4 counts were less than 50 as we expected. This patient was a 23-year-old girl. She was a college student. She was studying MPhil, and she came to us, with a history of chicken pox 2 weeks earlier, with a defective vision in her left eye. On examination, she showed a disc edema and a macula fan. So we thought some neuroretinitis has occurred, but when we did an indirect ophthalmoscopy, we could find the periphery white pale lesions suggestive of retinal necrosis. What was sad about this patient was she developed a rhegmatogenous retinal detachment in the eye even after starting acyclovir 5 times a day for 2 weeks, and then she went in for renal detachment. We did a pars plana vitrectomy under cover of antivirals and steroids, but her vision remained poor. She was only around CF even after the surgery, but retina was attached. This patient was referred from GH. He had history of fever, and he was dengue positive, and he had undergone blood transfusion because for platelet counts were low, and he referred as defective vision in the right eye. And when we looked at the fundus, we could see the pale disc edema with the hemorrhages and retinitis patches, and he had on FFA late of the filling of the vessels and occlusive vasculitis and retinitis, and he is a case of dengue retinopathy, and his vision remained around CF. This was a 35-year-old male who came to us with defective vision in the both eyes, left eye more than the right eye, and on anterior segment we found granulomatous KPs, mutton fat keratic precipitates, vitreous was mild haze was present, and disc showed disc edema in the left eye, and candlewax pericapillary cuffings like the perivasculitis and vitreous haze. The other eye showed pre-retinal nodules and mild peripapillary. And this HRCT was positive for bilateral hilar lymphadenopathy. AC was elevated. We started him on systemic steroids, and his condition resolved. This was another patient who came from a physician from other hospital, and he came in a resolving stage. He came like this. He had defective vision in his right eye. He came for second opinion to us. When he came, the disc was pale and he had a macular star. It's a resolved case of neuroretinitis. This is a picture which I have taken from the journal showing right eye vitritis, periphlebitis because of occlusive vasculitis and causing an optic atrophy. The fundus fluorescein showing the typical fern-like appearance in the midface because of the inflammation of retinal capillaries, which is pathognomonic for Behçet's disease. All these point out that disc findings are associated with uveitis. So to summarize, uveitis can be associated with disc findings. Whenever you have posterior uveitis, pan-uveitis, or retinal vasculitis, you can see associated disc findings. The disc findings will be disc edema, neovascularization of disc or pale disc or optic atrophy. And most of these cases will require systemic steroids, which is the mainstay of treatment. But if they are infective, we have to give anti-infective therapy. Like if it is ARN, we should give antiviral. If it is tuberculosis, we should start ATT, toxoplasma, anti-toxma therapy. Thank you.
Thank you, ma'am, for the great presentation. Now I would like to invite comments from Dr. Ratinam, ma'am.
It's a good presentation. I want to add only 2 points. One is for viral retinitis, acute retinal necrosis. Nowadays, we prefer giving valcyclovir 1 gram TDS for 3 months, which is very, which is published as equal to IV acyclovir. So oral acyclovir bioavailability is lesser than valcyclovir bioavailability. So we can add valcyclovir 1 gram TDS initially for 15 days, then see the patient again, and then continue so that the other eye will also be saved. That is one point. And another entity that can cause ocular finding is syphilis. Syphilis can cause optic atrophy. So only these 2 points. Other than that, multiple sclerosis can cause disc edema and uveitis. So that also should be considered.
Thank you.
Any other question?
Thank you, madam. Actually, association of MS usually presents with optic neuritis, but uveitis component, it is also association is a very rare phenomenon, isn't it, madam?
Yeah.
Thank you, madam. We'll move on to
just one input.
Yeah,
sorry.
please. No,
because I've experienced this, I just wanted to add this point. A lot of times in early VKH, especially Harada's disease, there is a lot of headache and disc edema. So there at least been 2 or 3 instances where I've seen patients who even undergone lumbar puncture and all, because the symptoms are very typical of meningism in early VKH, and they have disc edema. And if you don't look properly, you will miss the other findings in the fundus. So they've been misdiagnosed to have increased intracranial tension and undergone, even a child I've seen after a VP shunt. So early VKH, you should always keep in mind when you see a patient with headache and disc edema.
I totally agree with you. Yeah.
That was a valid point.
Can have only papilledema. Most of
Yes,
the time they
seen
go to neurologist.
Yes, ma'am. I've seen a girl who underwent a VP shunt, ma'am. That thing is etched in my mind, so I'll never forget that. She underwent a surgery to reduce increased ICT. So, and usually when they do those things, neurologists usually give them steroids also, IV steroids also. So these patients, once they develop IV steroids because for increased ICT, they immediately get better also. There's a transient improvement for the first 2 weeks.
Yes.
And then after the steroids are withdrawn, they again worsen, and then they get the full-blown signs of VKH.
Yeah, only then KPs appear. Yeah.
Yes, ma'am. Yes, ma'am.
Okay.
That's all, ma'am. That was my point.
Thank you. Thank you. That was a valid point taken. But most of the times what happens is if you see only the disc and the macula, you tend to miss the serous detachments because I totally agree. We too have seen patients coming to us from the neurologists who were treated as IAH, but on seeing the full of the IO, we could detect the serous detachments. And if you are in doubt, you can do an OCT also to pick it up. So this was, I think that was a valid point you could, you suggested. Next, we will
make one comment, Dr. Padmavati.
Yes, sir.
Yeah, no, so for the same reason, like we see only the disc and the macula, ARN can be missed in the periphery. So we have had patients treated with steroids without antivirals and the ARN spreading like a brush fire. Acute retinal necrosis.
Okay, sir. Yes,
Yes.
sir. Okay, shall we? I think we will move on to the next topic. I have the pleasure of introducing Dr. Kalai Selvi. She is an alumni of Madras Medical College. At present, she is the professor in RIO GOH. She heads the neurophthalmology department. She has worked as a professor in Theni, Tanjavur, and Madurai Medical College. Over to you, madam.
Good morning, one and all. Am I audible?
Yes, madam. Please share your screen.
Yeah, sure. Yes. Good morning, one and all. And at this outset, I'd like to thank TNOA and Aravind Eye Hospital for giving me this opportunity to speak in this platform. And my topic will be approach to disc failure. My previous speakers have all spoke about unilateral, bilateral, and disc edemas and tumors. And of course, the final sequelae of all that is optic atrophy, which is nothing but the failure of the optic nerve head, with patient presenting with subtle dysfunction to complete blindness. Most often we see it as an incidental finding, so particularly if it is monoocular, patients are not even aware that they are having a defective vision. And usually it's found out in a routine neurological or ophthalmological examination. So as it is not a disease, but just a sign of an underlying disease. And you have the pathology is, of course, a reversible damage of the ganglion cells up to the lateral geniculate body, where there is axonal degeneration with proliferation of glial tissues and reduced capillary vascularity, which is seen as a Kestenbaum sign with loss of tissue. Usually, failure signifies that optic neuropathy has occurred at least 3 to 4 weeks prior. And you have varied etiologies or classification for optic atrophy based on the pathology, based on the clinical finding, and based on the etiology. So here we have a classification where they say an ascending optic atrophy or a Valerian degeneration, where the primary lesion is in the retina or optic choroid, and the atrophy proceeds from there towards the brain. Or you have a descending optic atrophy where the lesion is in the intracranial and then it proceeds towards the optic nerve. Or there is a transneuronal degeneration where there are neurons on one side of the synapse degenerates as a result of loss of neurons on the other side. And based on the clinical finding or the fundus finding, this is a picture showing a primary optic atrophy where there is no preceding disc edema, lesion is in the anterior visual system, and the optic nerve head is disc margins. This is chalky white in color. The disc margins are quite distinct, and the surrounding retina is completely normal. And here the architecture of the optic nerve head is well preserved. When you talk about secondary optic atrophy, this is a fundus picture of a 15-year-old male who came with chronic papilledema going in for optic atrophy. So there was a marked disc swelling and marked degeneration. Here in secondary optic atrophy, there's a marked degeneration of the optic nerve with profuse glial proliferation and the swelling of the optic cup. Here you can see a dirty gray with the margins are very indistinct, tortuosity of the vessels and so on. So this is clearly a secondary optic atrophy. This is a case of central retinal artery occlusion with sparring of the cilioretinal artery of a male patient. And here this is a consecutive optic atrophy where the disease is mainly of the retinal vasculature or in the choroid. There's a waxy failure of the disc with attenuation of the arteries, and associated retinal pathologies can be seen well. And cavernous optic atrophy, of course, this was dealt in detail by Neetu Mohan ma'am about glaucomatous disc. Here, there's axonal degeneration without proliferation of glide tissue. Where there's formation of caverns with the excavation of the optic disc and the caverns being filled with hyaluronic acid. Here, we see a vertical cup disc ratio of at most 0.9 with a very thin neuroretinal rim with bionating and nasalization of vessels and so on. The next one is segmental optic atrophy or temporal pallor, where the most referrals are for temporal pallor to the neurophthal department or disc hyperemia. They have confusions as is it pathological or not. So most of the patients are referred either a temporal pallor or for a disc hyperemia, but as to as whether it is an early papilledema or not. So temporal pallor, normally itself when you see the disc is the disc side, the temporal side will be bit paler than the nasal side because of the arrangement of the size of the physiological cup, and the temporal nerve fibers supposed to be a thin and translucent. Less vascularity or the less number of capillaries on that side of the disc also makes the temporal side appear more paler. And if there is a temporal pallor, we have to look for any discrete papillomacular bundle lesion. Usually the patient presents with central cecal scotoma, most common seen in dominant hereditary optic atrophy or toxic or nutritional optic neuropathy. You also have non-pathological pallor of the optic disc, particularly this temporal pallor, as I said earlier. The temporal pallor is more often confused whether it's pathological or just normal disc pallor. Sometimes marked recession or excavation of the physiological cup can present with a deep cup, which can be confused with disc pallor. And of course, as earlier discussed, axial myopia, where the optic nerve enters the globe obliquely. It's when we view the disc, it might appear or give an illusion of disc being paler. Or fresh batteries or new bulb, as they say in ophthalmoscope, depends on how the incident light falls on which part of the disc. Also gives an appearance as optic disc pallor. Even the age of the lens, according to Walsh and Hoyt, they've done a study where they say even the age of the lens, as the lens becomes aged also, it can give an appearance when you see the disc through it. The disc might appear paler, and in pseudophakic patients as well, the disc might appear paler. And of course, other conditions where pseudo-optic atrophy, this was dealt in detail by Dr. Mahesh Kumar, optic drusen, morning glory syndrome, myelinated nerve fibers, and so I'm not discussing that in detail, so it's already been dealt. But to keep in mind, when you see a patient of disc pallor, these conditions also to be ruled out. So the etiological classification, of course, post-inflammatory and post-infective, trauma, metabolic, toxic, nutritional ischemic, consecutive, hereditary, or compressive lesions are more common. Depending on the almost in pediatric or young adults or elderly people, I think this overlap. But particularly if you come to the children or a pediatric age group, most common we see is post-hypoxic ischemic encephalopathy, hydrocephalus, and then inflammatory or an infective etiology. When you come to young adults, I think we see more of a traumatic optic neuropathy because RT is nowadays with we see a lot of patients with traumatic optic neuropathy followed by inflammatory and infective. And elderly patient, it's usually the vascular or ischemic causes following with inflammatory or compressive lesions. These form the major etiological factors for presenting with optic atrophy. Now, how do you approach a patient, clinical approach of a patient with optic atrophy? Detailed history. I think this history part is very important where the residents lack, I feel they are more into investigation than talking to the patient. So I feel a bit of a history, detailed history to be asked. I think that gives you a lot of clue as to the diagnosis, how to make a diagnosis or what can be the etiology. Particularly in children, when they come with an optic atrophy, I think we start with the antenatal history, perinatal, postnatal, where there's any history of birth asphyxia or prematurity, history of any neonatal seizures, developmental history, delayed milestones. All these can give a clue to the diagnosis. And particularly, as I said earlier, the ischemic injury, hydrocephalus, these are all the common causes. And adults, of course, it can be traumatic, inflammatory. Elderly, it can be vascular or ischemic. Gender, female, of course, female optic neuritis, idiopathic intracranial hypertension, or meningiomas are quite common. Male, it can be ischemic or infiltrative or a traumatic optic neuropathy or common. When it comes to ocular complaints, you can ask whether that can be, was it an acute or a subacute onset with a painful or a painless loss of vision. I think this can give you a clue with optic neuritis, pain on eye movements or a sudden painless loss of vision can be more of an ischemic. And if it is going to be a gradual progressive vision loss, it can be either a nutritional or a toxic optic neuropathy. And coming to laterality, of course, you have unilateral and bilateral. Most commonly, unilateral is always mostly optic neuritis or ischemic etiology, whereas bilateral can be a papilledema or toxic or nutritional or hereditary optic neuropathy. All these can be bilateral. So this can all give you a clue as to the diagnosis. Associated symptoms, of course, history of headache, vomiting, diplopia, can be a raised ICT, transient ischemic attacks, jaw claudication, fever, malaise, motor weakness, ataxia, deafness, or any musculoskeletal abnormalities should be looked for. Family history, if it is hereditary, the history in the siblings or members in the family can give you a clue to diagnosis. Of course, the past medical history is quite important, like diabetes, hypertension, dyslipidemia, whether the patient is on ATT or particularly ethambutol toxicity or anti-epileptic measures. All these can give you a clue to a diagnosis. So a detailed history taking is very important. And if you examine a patient of the optic atrophy, most probably visual acuity can be a subtle dysfunction, or they can present up to with no perception of light. But we do see patients where they have a dispeller, but the patient has a reasonably good vision. So not all optic atrophy need to present only with no perception of light. And pupillary evaluation is very important, where it shows an afferent pupillary defect, an RFPD or a sustained pupillary reaction. Color vision, yes, the red, usually the red saturation is there, and red-green defect is always involved when the optic nerve is diseased. And slit lamp examination can give you a clue like whether there's any previous inflammation or disc nodules can be seen in that. Now, and the next thing is examining the optic disc. So what do you look for and how to differentiate can be seen from the examination of the optic disc. Special attention to be paid to the color of the disc, the edge of the disc, whether it is unilateral, both the discs are symmetrically equal, or one disc is less affected or not. The size of the disc shape, and the color of the disc is normally salmon pale. The cup disc ratio and the neuroretinal rim helps it to differentiate from glaucomatous optic atrophy. Sometimes the referral can be to you, and when you see it can be a glaucomatous, whether it is paler more than the cupping or cupping more than the paler. That's the question there. So the cup disc ratio and the neuroretinal rim can give you a clue whether it is glaucomatous or not. The disc vascularity, which is the Kestenbaum's count, let's say optic atrophy, normally it is 10, and in optic atrophy it is less than 6. Of course, the surrounding peripapillary area, whether there's any atrophy to be looked for, and retinal nerve fiber layer defects should be noted, which is best seen with a red-free green filter. And almost never miss to see the macula, whether there can be a macular star or a serous chorioretinopathy, where we focus just only on the disc and leave the macula alone, we might miss the findings. So how do you go about evaluating when a patient presents with a pale disc? As I said, a complete detailed history I feel is very, very important. Following with your examination, ocular and systemic examination is very much needed here. Look for all the general examination, pulse, blood pressure, conjunctival pallor, look for iris, signs of malignancy, lymphadenopathy, cardiovascular, respiratory, gastrointestinal, and the central and the peripheral nervous system need to be examined in detail to look for the causes. These can give a systemic clue as to what it can be, like frontal passing or cachexia or skull deformity. Ocular investigations, the first and foremost visual acuity, of course, color vision, contrast sensitivity, visual fields, either it can be a central cecal scotoma, or it can be a bitemporal, or it can be an altitudinal defect, or it can be a tunnel vision, which can give you a clue to the diagnosis. And the fundus photograph, yes. And OCT of the optic nerve head and the retinal nerve fiber, which will give you the status. And when it comes to electrophysiology, visual evoked response is preferable when, particularly if it is an optic neuritis, there can be a delayed P1, which can give you a diagnosis. Suppose the patient comes with even an optic atrophy or a disc failure, or if it is going to be an ischemic, the amplitude can be reduced rather than the delayed P1 responsibility. And if there is any associated retinal dysfunctions, of course, you can go for a electroretinogram and oculogram. And finally, of course, MRI or a CT, depending, suppose a patient has a traumatic optic neuropathy and disc failure, whether there's any impingement of the fragment of bone on the optic nerve, the CT can pick it up well with the CT orbit, or an MRI brain to look for any other meningiomas or any mass lesions, or an MRI angiogram to look for aneurysms or an ischemic. All these can be seen with this. And apart from that, your systemic investigation, depending on the other systemic findings in the body, then maybe you can go for those systemic investigations like hemogram, liver function test, ESR, Manto, VDRL, or lumbar puncture if it is an idiopathic intracranial hypertension, and specific investigations for sarcoidosis or collagen vascular disorders, tuberculosis, or toxic neuropathy if it is a screening, or vitamin deficiencies, serum B12 and folate levels, thyroid eye disease, particularly DEVIX or paraneoplastic syndromes. Management, of course, there's no specific treatment for optic atrophy. We all know that. And the underlying inflammatory or ischemic or the things should be treated. And if there is any causative medication like ethambutol toxicity, just stop the drug, or if toxin just avoid, or if it's going to be a vitamin deficiency, do replace it with vitamins. And of course, when patient present with low vision, may benefit with low vision devices. So just a few, this is a patient, male patient presenting with retinitis pigmentosa, waxy failure of the disc. This was a 51-year-old female who presented just 2 days back with a temporal pallid disc edema of non-arthritic anti-AION. And this is a patient who presented with a cavernous optic disc with a CSR, just to show the different types. And this was the patient also who presented recently, just 2 days back, with the left eye of the 636 vision, previous history of non-arthritic AION, presenting with disc failure, and now she's presented with a right eye mild disc edema with a mild blurring of vision, though her vision is 6966. We are evaluating this patient just to show you the different cases. In conclusion, I would say, though the optic atrophy, depends on the treatment, depends on whether it's a static or a progressive. Usually we give a guarded visual prognosis to the patient, but still if the condition keeps worsening, I think we need to identify and treat and preserve the vision for the patient. Thank you. Thank you for the patient listening.
Thank you, madam, for the great lecture. Actually, this is one gray area in neuro-ophthalmology where you don't have a series of investigations turn out to be negative and we don't know what to do. It was nice knowing how to approach a case of disc pallor. Mahesh Kumar, any comments, Dr. Mahesh Kumar?
Excellent compilation, and I mean the detailed history taking has been adequately emphasized for the postgraduates, and I think it's a great learning for all the postgraduates as well as the clinicians, because as it is, optic atrophy is nothing can be done, That is a generalized generalized thought, but it should not be like that. We need to assess the cause of the optic atrophy to potentially prevent a similar one happening in the other eye, or even possibly recover the present eye to some extent. The history and the findings has been excellently covered. Thank you.
Thank you. Thank you, Manish.
Right.
There is one question in the chat box, which I am not able to answer. Why discuss waxy pallor in consecutive disc atrophy?
So I think there's more of a glial tissue,
Glial
which
tissue,
gives
yeah.
it the waxy pallor of the disc.
Yes. Yeah, because in secondary pallor also we have more of a glial tissue, but I'm not sure how it's different in this waxy pallor. Maybe again connected to the glial tissue only.
Yeah, but maybe the secondary optic refractory, they say there's a massive proliferation.
Massive
You know,
proliferation,
that
okay.
you don't see the cup or anything.
Okay.
Maybe that's why, that gets its color. And here we don't see that much of glial tissue proliferation. Maybe, I mean, I just might be sometimes certain things cannot be explained.
Explained, yeah. Maybe associated retinal pathology is.
Yeah, retinal pathology is also there.
Yeah.
Yes.
Is my slide visible?
Yes, Dr. Padma.
Yeah.
Yes.
Thank you.
No, full, it has to come in full
Yes,
screen.
madam, I'll give it in the presenter mode.
Fine.
Yes, sir. Right. The topic assigned to me is imaging of the optic disc in neuro-ophthalmology. I think my job has been done easy with all the speakers speaking about the pathology. Any advancing technology always has a fascination to the humans. Similarly, any new imaging modalities also will always be an interest. And moreover, these imaging modalities have revolutionized the field of ophthalmology. So what are the images? We have so many imaging modalities which have been introduced into the field of ophthalmology. So this is necessary for the evaluation, management, and treatment of neuro-ophthalmic disorders.
Sorry to interrupt, Dr. Padma. Is it in slideshow? There are two slides we are seeing here.
Okay.
The present slide and the next slide also.
Okay, fine. I think I have put it in the presenter mode.
Presenter mode, yeah, please.
Yeah, right.
And now it's fine.
Okay, right. So we have no many imaging modalities which have been introduced in the field of neuro-ophthalmology. So what happens is, what are these available? How do you image the optic disc? I think fundus imaging, ultrasound, optical coherence tomography, computer tomography, magnetic resonance imaging are all the imaging modalities available. So how do you use these? Many times, though fundus imaging has been way long back, still it holds its place in documenting the disease process. Why you need to have a fundus imaging is when you see or a follow-up visit or a sequential follow-up, it helps you into document the disease process. This also helps you in treating the condition. So this is the fundus image when you have a disc edema, where you have a sectoral hyperemic disc edema with a sectoral pallor. You can see this is a red-free photograph. This also, it uses the green filter to visualize the vasculature as well as the RNFL very clearly. Here you use a monochromatic light to visualize the pattern. This is helpful in cases of media opacities. Apart from that, this doesn't use the necessitate the use of any contrast. Whereas the other imaging modality is the fundus imaging, and fundus imaging where you use contrast is fluorescent dye, where you tend to inject fluorescent and note the leakage and diagnose certain conditions. The next is your fundus autofluorescence. This helps to document the intrinsic autofluorescence within the disc. What usually lipofuscin is the autofluorescent thing which is present in the RPE. This is so what happens is when you put a fundus autofluorescence, this will try to emit the fluorescent. So you train when you have a disease of the RPE, you don't pick up this autofluorescence. This helps to distinguish a drusen. Many times the dilemma a neuro-ophthalmologist faces is between a disc edema, or is it a disc edema or is it a pseudo disc edema? Apart from the clinical examination, what else imaging modality you have to diagnose the condition? What supports you? One is your ultrasound, which is available in your clinic. This helps you to distinguish true edema versus pseudo edema. Apart from that, it also establishes other etiology of disc edema and in cases of any trauma. So you have the 30-degree test, which helps to perform the ultrasound in primary as well as in the 30 degrees away from the primary, so that you can measure the optic nerve sheath diopter. And this distinguishes when you have a more than reduction in the 20% of the diameter reduction. This is considered to be a positive. So when you have a change, why do you have this changes? Because of the redistribution of the optic nerve fluid. CSF fluid in the optic nerve sheath. So this is an image. I think this show where you pick up a disc edema, you can see the crescent sign, and this is the optic nerve head, or you can call this as a Doughnut sign. The other condition is in cases of posterior scleritis, where you have a disc edema, you pick up the thickening, RCS thickening with a inverted T sign. The next is in cases of optic disc drusen, do a simple B scan, you can detect the calcification. In case of direct traumatic optic neuropathy, you can see the avulsion of the optic nerve head. When you see the compare the imaging modalities of resolution as well as the imaging, you can see that the optical coherence tomography has a resolution of 2 to 10 microns, whereas on your ultrasound for 150 microns with CT and MRA up to 1 mm. But if you see the depth of penetration of the tissues, it is greater with the magnetic resonance imaging. So the next is the optical coherence tomography. This is a non-contact, non-invasive technique. This is for imaging the biological tissues. This was first, the concept was first produced by Adolf Fischer. So this is a objective, quantitative, reproducible assessment of optic nerve and macula. This gives a histology of the optic nerve head. So what is of this? It has the evolution of OCT has gone from stratus OCT to the swept source. So there are many advantages in the swept source, where you have 1 lakh to 4 lakh scans per second, and you have your resolution is very much high, and the range of imaging is from the posterior cortical vitreous to the sclera. So as a neuro-ophthalmologist, what is the purpose of the OCT? When should I do? Before I move on to my case presentations, this is a printout of the OCT or optic nerve head and RNFL analysis. If you see in this, you have the retinal nerve fiber layer thickness depicted as a graph. You have depicted RNFL thickness as an average clockwise, which is in quadrant wise, and one which is in the where you have the RNFL thickness in the of the normal. Apart from that, you have the RNFL thickness map, which is color coded, and you have an infrared image with the deviation map. This RNFL, measuring the RNFL thickness, it gives an amount of the thickness only. When cases of atrophy, it is thinned out, but it doesn't give you an etiological diagnosis. Apart from that, you have the color, this is the tomogram, and this is the color coded parameters, which is compared with the normative data. As a neuro-ophthalmologist, we are also interested in the ganglia cell analysis, where you need to look at the GCC IPL thickness. So this is an overlaying infrared image, and this chart denotes the ganglion cell layer with the inner plexiform layer thickness for each sector. And here you have the horizontal B scan through foveal pit. So this is a manual segmentation, where this is the RPE layer, and you have this is the disc. This corresponds to the disc. The optic disc can be imaged in a 2-dimensional as well as a 3-dimensional pattern. You have to be more concerned about the RPE as well as the Brooks membrane. Usually this is almost deflected like this as shown by the arrows. When you have a disc swelling, you have an acute angle which is more towards the vitreous. This was a 17-year-old female. She presented with a blurred disc margin. The question was whether she has a papilledema or not. I did a fundus autofluorescence, couldn't pick much on the anything. So, but however, the enhanced depth imaging, which is a modality which is available, has picked up the buried optic disc drusen. So this enhanced depth imaging is one gold standard, which visualizes the structures deeper than 500 to 800 microns. Here you have the optic disc drusen, which appears as a poor signal core surrounded by a hyper-reflective margin. There is a consortium for the optic disc drusen, which has a recommendations for diagnosing optic disc drusen, and they have an OCT protocol to diagnose, to check for optic disc drusen, whether it is superficial or buried. I would like to stress upon one entity where you have the peripapillary hyperreflective mass-like structures. This is in contrast to optic disc drusen. These are hyperreflective. They don't have a sharp outer margin or a hyporeflective core. They are often lie external or to surrounding large parts of the disease. They do not do not autofluorescence. These are not visible on ultrasound. And this is an OCT finding which could be seen in patients with papilledema or even with optic disc drusen. So what the histopathology sees that it is, this corresponds to the lateral bulging or herniation of distended axons into the peripapillary retina. So based on this, they have given the criteria that optic disc drusen, they are always located above the lamina cribrosa, whereas these PHOMs, they have a hyporeflective core, hyperreflective with an ill-defined margin. So in order to distinguish true versus pseudodisc edema, is your OCT or RNFL thickness gives you any sensitivity? Based on this study, they found that thickness of more than 127 microns gives 73% sensitivity and specificity in differentiating pseudopapilledema from papilledema. But however, this alone is not essential. You need to do a peripapillary retinal thickness, which helps in differentiating the disc edema, or maybe you can go for a serial peripapillary RNFL thickness. As I said earlier, the RPE Brooks membrane in papilledema, it has an inverted U shape, whereas in an ischemic optic neuropathy, it is a V shape. This is a case of normal disc, and if you see, this is a case of papilledema. Disc edema is C. If you can see the deflection here, which shows that it is a deflection of the Brooks membrane. You can do a serial follow-up of these patients and this deflection comes down. So that is how you monitor these cases. As suggested, this is a toolbox for distinguishing papilledema, optic disc edema, and pseudopapilledema. Moreover, you can distinguish between optic neuropathy and retinopathy. The peripapillary RNFL thinning, this is diagnostic of optic atrophy, but however, it doesn't differentiate between various causes. The macular ganglion cell complex is one entity which could help you in the diagnosis. This was one case where we had a papilledema in one, I think I can magnify and show. You can see the RNFL thickness is very high in this, the 447. But on follow-up, the RNFL thickness has come down to less. And on follow-up of these patients, you have the ganglion cell loss, which is indicative of pallor as well as optic atrophy and vision loss. So we had done a prospective studies where we could track the RNFL changes in cases of IAH, so that how they were responding to treatment or they had a recurrence. This helps you in guiding your monitoring the disease. So this is how, that was a photograph when you had where one of the patient had, had regression of the disease. This was a 24-year-old female who had a sudden loss of vision in the left eye. She was a diagnosed case of optic neuritis. The OCT, if you see, you don't have much of a disc edema, but and the GCC was also absolutely normal. But after treatment, after follow-up of 3 months, if you can see, There is a mild temporal pallor, except for the mild temporal pallor, but however, the GCC shows much thinning, which is more significant. So you could follow patients of multiple sclerosis or NMOSG, and you can distinguish based on the thinning of the macular ganglion cell complex. In cases of macular ganglion cell complex, this demonstrates better structure with vision and disability. The ganglion cell monitoring is done for disease progression. Moreover, the peripapillary RNFL loss is more significant in NMOSG associated with MGCC thinning. The subclinical peripapillary RNFL damage is rare. You may also see some amount of microcystic edema in some cases of NMO. Neurodegenerative diseases also, you tend to do an OCT where the macular ganglion cell thickness is the biomarker for diagnosis and progression of the disease. So you can monitor any neuroophthalmic diseases with IHM of these diseases with OCT. This was a 44-year-old female. She was a diagnosed case of pituitary macroadenoma with a chiasmal compressive lesion. She had a visual acuity of 660 in the right eye, left eye 680. This was her OCT printout. If you can see, there is a GCC thinning at the presentation itself. But after surgery, you can see there is improvement in the visual field, but however, the GCC thinning was still very much reduced. So this was an article which was published in the Journal of Neuro-Ophthalmology, where they had said that ganglion cell complex in chiasmal lesions, you can identify the patterns based on these are usually correlating with the visual field loss. And this could also be seen with minimal or no detectable visual field loss. Moreover, after decompression, the majority of patients showed improvement in visual fields despite persistent GCC loss. So these patients with less GCC loss had more better postoperative visual fields and recovery. So this could be used as an objective method to diagnose and follow patients with chiasmal lesions. In case of non-arthritic ANOVA, you can do they had done a longitudinal study of 16 eyes. They found that significant thinning of the GC-IPL complex was seen as early as 2 days of onset. So this is one distinguishing feature from that of an optic neuritis. And moreover, this thinning also could predict the visual outcome. So this helps in prognosis of neuro-ophthalmic diseases, especially the compressive optic neuropathy in a non-arthritic AON. The OCTA is one thing which visualizes the vascular network in the retina. You do a repeated B scans at a particular location. This provides angiographic and structural correlation. This is a picture of the superficial capillary flexus, and this is the deep one. So as such, the usage in OCTA is limited from our side, but still there have been publications in cases of non-arthritic AON where they measure the vessel density and the flux index. This is a case of normal disc. You have the superficial capillaries and the deep capillaries. The red points shows the vessel flow, and this is the peripapillary RNFL thickness. So in case of non-arthritic AON, where you have a segmental pallor, you have a reduction in the volume of the vessels in the superficial as well as in the deep. There is a visual field defect inferiorly, which corresponds to the RNFL thinning also in the seen in the map. So they have regarded many capillary dropout along the capillaries in at least 2 quadrants in 100% and 50% of the non-acute cases. So this OCTA is usual to measure the vessel density as well as the, but apart from that, you don't have any other information. There are much studies still going on to know in various diseases. So OCT as such in neuro-ophthalmology, it is for diagnosis, monitoring, view the side effects of any neurological disease and prognosis of neuro-ophthalmic disorder. The next last but to least, which has been well covered, I just wanted to share some few photos of CT. When do you advise a computed tomography? When do you advise an MRI? This is an ionizing radiation, which visualizes it. When you have an injury, trauma, fracture, you can do a simple CT. But when you want to see the pathology, it is better, or soft tissue lesions, it's better, you do an MRI. So this is one case where the patient had a right optic nerve transection because of a direct injury. This is a case of optic disc drusen where you can see the calcification when in suspicion you want to rule out. But this is one case where there was a disc pallor. It was a case of narrowing of the optic canal. In the same patient, you can see the thickened skull bone. This was a osteopetrosis. MRI imaging modality, this is advised only in cases where you have bilateral disc edema due to raised intracranial pressure, or it could be due to secondary to optic neuritis. You have to do it. You have the kinking, flattening, and enhanced of the, this is a coronal section which shows enhances or enhancement around the optic nerves. In case of optic neuritis, you need a gadolinium enhanced contrast MRI, which could detect any perineural enhancement or thickening or T2 hyperintensity of the optic nerve. So this is the algorithm when you have an optic neuritis or a compressive optic neuritis. So to conclude, a proper clinical examination with relevant investigation modality is needed for proper management of the disease. Thank you.
Thank you, ma'am, for the wonderful talk.
Any comments? Mahesh?
Yeah, you covered everything, Padma. It's a wide topic and beautifully covered. I don't think I have anything to add to that. And
I agree, Padma. It was a very good talk.
Thank you, madam. RK sir?
Yeah.
I have to ask you only.
It's very good, yeah. Because you started
I have one
now.
question, sir.
Yes, Ram. Yes, yeah.
No, ma'am. Ma'am, how much weightage, other than clinical examination on a 90D, how much weightage will you put on a OCT to prove or disprove disc edema?
I would give only, I wouldn't give much weightage. It is only an ancillary testing to say the truth. It would be only to substantiate your diagnosis. That's it. Hope I am not wrong. That is my funda. If I would like to
why asking you this question is, a lot of times, though it is easy to talk, but a lot of times we are faced with patients who have some vague headache and the disc doesn't look normal, but at the same time, it is not a clear-cut papilledema. Or a lot of times somebody has diagnosed papilledema, so when you look at the disc, it does look edematous, that sort of thing. So you are, finally it comes to you to decide, say yes or no. A lot of times what we do is we do an OCT, but we just monitor on OCT and say, okay, it looks the same across months and it's probably just an anomaly and not really an edema.
Yes,
but
sir,
how much weightage?
Weightage we will give on the OCT when you are in a dilemma only. You depend.
Exactly.
You monitor the patient based on the OCT. If you don't find a change, then you can stop short of any treatment. Just observe the patient.
Yeah, that's all. So in a single OCT doesn't really mean anything.
A single OCT doesn't mean
if it's an in-between case. If it's an in-between case, if it's frank, it's a different thing. I agree with what you're saying. If it's frank, it's different. So single OCT doesn't really mean anything.
But I give a period of time. I always ask for a review for after 15 days. I do an OCT repeat. Then I re-evaluate myself as well as the patient.
Good, ma'am. Good, ma'am. Yeah, because a lot of times. Yes, sir. Please, sir.
Is there any role for OCT angiography in AIY with arthritic, non-arthritic? Its role.
Sir, you can only distinguish the flow or detection. That's it, sir. Nothing. We are not diagnosing. All the conditions are diagnosed clinically. These are all additional or ancillary testing methodology to document as well as to monitor the progression. Apart from that, you don't have anything else to substantiate your diagnosis.
Okay.
For OCT angio, sir, by you is it will image the superficial capillary plexus on the optic nerve head. So if there's a dropout on the optic nerve head, it can pick up.
Okay.
But AON, especially non-arthritic, is occlusion of the posterior choroidal vessel.
Yes, sir.
Short SPCS, short posterior choroidal vessel. So the OCTA doesn't go that deep. It doesn't go beyond your sclera to show the vessels there. At best, it goes into maybe superficial choroid capillaries maybe. Even that is a little difficult, but newer machines are able to visualize up to choroid capillaries and to some extent large choroidal vessels. So it doesn't really go into the posterior choroidal, short posterior ciliary arteries. Dr. Mahesh sir is not there. Maybe Parag, if he's still online, maybe he can add a couple of points. I don't think an OCT can penetrate that deep as of now. Current technology OCT cannot penetrate that deep.
No, sir. You
Unless the
need to add,
superficial
I would like
plexus
to
itself
say,
is ischemic, then maybe yes.
you need a different algorithm to have a segmentation as well as to see the deep penetration. It doesn't come along with the machine, sir. So you have to install a new software to see the segmentation as well as the penetration. No, as such, the machine doesn't comes with that, sir.
Okay.
Yeah, true, ma'am.
Thank you. Thank you.
There are two queries in the chat box, one on tuberculosis, uveitis, and one on neuro OCT.
I 1 minute. Let me question. I just have the look. Yeah, I think, Doctor, is OCT useful in deciding treatment? No, I don't think it is an adjuvant for monitoring only. For the thickness, as I said, it could distinguish between multiple sclerosis and the neuromyelitis spectrum. It is only for prognostication as well as documentation. Treatment is only on your clinical acumen.
Uveitis is already answered by Vanilla.
Yeah, I think
Okay.
we are running short of time. We'll go on to the last talk. I have Dr. Madhavi to speak on imaging in glaucoma.
Thank you, ma'am. At the outset, I would like to thank Dr. R.K. sir, President TNOA, Dr. Padmavati ma'am, and TNOA for giving me this opportunity to be among the elite speakers. I'd be talking on optic disc imaging in glaucoma. I have no financial disclosures. So why did we have an entire webinar on optic nerve head? I would like to compare it to a vital cord which connects the CPU to a monitor. So glaucoma, as we all know, it's a very common disease and it is going to be much more common in future. So early diagnosis is the key to prevent this irreversible blindness. So the definition of glaucoma has kept on evolving. Initially, it was just a disease of the intraocular pressure. Right now, the focus has shifted to the optic nerve with IOP remaining a risk factor. So glaucoma is characterized by a chronic progressive optic neuropathy with optic disc changes and visual field defects, which may or may not be associated with a raised intraocular pressure. The question is, do we need all the three to make a diagnosis? So the World Glaucoma Association in their 10th consensus clearly told that the clinical diagnosis of glaucoma is predicated on the detection of a thin retinal nerve fiber layer and a narrowed neuroretinal rim. And it does not always require the detection of visual field defects with perimetry. So when we are talking about optic nerve head, we are essentially talking about the structural damage. The structural damage precedes the functional loss by an average window period of around 6 years. That means approximately 50% of the RNFL has to be lost before we detect any visual field damage. So we would like to pick up glaucoma as early as this pre-perimetric stage or even in the progression in the green stage. So there are a wide range of instruments available to image the optic disc, starting with the fundus camera, the GDX HRT, which has gone out of the picture, and the current hero in the field, OCT. I'll be talking mainly on the fundus imaging, the OCT, and the OCTA in the point of view of a glaucoma specialist. So fundus imaging, the strength is that it is really good for documentation. And also, it has a higher sensitivity in detecting disc hemorrhages when compared to a clinical examination. And with the onset of COVID, the fundus photography also had many advances, ranging from handheld fundus camera to smartphone fundus camera, and also a self-aligned fundus camera. And with the AI coming into the picture, the fundus images has been incorporated with AI for screening purposes. But the problem with the optic disc, or I call the riddle of the optic disc, is its variability. Just like our fingerprints, the optic disc is so variable, so varying presentations. So the fundus imaging becomes a subjective examination rather than an objective examination. So let's talk about OCT. So Madam has covered a great part of the OCT. I'll be concentrating on the glaucoma point of view. So from glaucoma perspective, we are looking at the optic nerve head, the parapapillary retinal nerve fiber layer, and the macular ganglion cells. So initially what the machine actually does is it locates the Brooks membrane opening and it draws a circle as the disc margin. Then next it detects the cup margin. So between these is the neuroretinal rim. Then it has a calculation circle with the center of the optic disc and 3.4 mm. So this is done in the clockwise manner in a temporal superior nasal introtemporal or a TSNIT pattern. So this is how the cirrus printout looks like. So date of birth, what is the significance of date of birth is that most of the data in this printout is based on the age match normative database. And to assess the quality of the scan, we should have a good signal strength. The size recommendation is more than 6. So the RNFL thickness map and the deviation map is very important. Just like we have raw data in the HFA, the thickness map is for the topographic analysis. And in the thickness map, the blue color or the cooler colors indicate areas of thinning, while in the deviation map, which is based on the age match comparison with the age match normative database, you will have the warmer color. So this is in contrast to the thickness map. So this is a hourglass pattern which is normally seen in the RNFL thickness map. This will be lost in case of any RNFL thinning, where you can see actually blue areas and which will be reflected in the deviation map as a hotter colors. The same will be reflected in case of advanced glaucoma. Areas of cooler color will be showing marked thinning. So the next part is the RNFL thickness. The RNFL thickness is displayed in the form of a TSNIT plot, a clock-hour and a quadrant analysis. The TSNIT plot has a double hump configuration. So again, this has been color coded for easy interpretation with red indicating marked damage. So next is the neuroretinal rim thickness. This is again in the form of a TSNIT plot and also it is color coded. So the next part, this is a tabular column which shows the cup parameters, basically optic disc parameters, and the cup parameters will be displayed in this. You can see this area is indicated in gray. This is because this is not in comparison. The disc area is not in comparison with any age match normative database. The rest of the part of this column is color coded. So in compared to the last example, we are seeing here many places are coded in gray color. This is because the size normative database includes only a particular disk area, that is 1.3 to 2.5. So beyond that, if it goes, the other areas also cannot be compared to the age match normative database. So any comparison which is not made, that areas will be represented in a gray color. So as I said previously, the cirrus OCT normative database has a refractive error which ranges from -12 to +8 diopter and age ranging from 18 to 70. And we have only 1% of the Indian representation in the database. So next is the horizontal, vertical and circular tomogram. We should look at these because this is where we have to look for the segmentation errors. This is also essential for assessing the quality of the OCT scan. So the next parameter is the ganglion cell analysis. So in the macula constitute 50% of the retinal ganglion cells. And we all know the ganglion cells are going to be affected in glaucoma. So what cirrus does is in the ganglion cell analysis, it calculates both the GCL and the IPL as a complex. Some OCT machines even include RNFL in the analysis of the macular analysis. Again, this also has a thickness map and a deviation map. This has a topographic or the actual analysis, which is again, you can see an area of thinning, which is coded as blue. And the deviation map, again, in contrast to the thickness map, will be displayed in the form of gray in case of thinning. This is a normal macular cell ganglion analysis, which is shown here. So there is something which is called panomap analysis, which is actually a wide field structural damage assessment. So in this, both the RNFL, ONH and the ganglion cell analysis are integrated together for better understanding and for better interpretation. And apart from using for diagnostic purpose, the GPA is a very structured and statistical analysis package, which helps us to monitor glaucoma progression. So there are two types of progression analysis, that is a trend analysis and the event analysis. So in the event analysis, what the machine actually does is it compares the current data with the baselines. And again, for the ease of interpretation, everything is color coded. You can see the possible loss in yellow, the likely loss in red. And then it for trend analysis, it builds a trend indicating and predicting how much the patient is going to progress. All of these will be color coded. And this is the summary of all the parameters in each examination, in the baseline and the current examination. Again, these are color coded for ease of interpretation. So talking about OCT, one should consider artifacts and anatomic variations before jumping into a conclusion. So appearances can be deceiving. All that is red, it is not glaucoma, and all that is green cannot be normal also. So let's look at few examples. So how motion artifacts or saccades affect the OCT, you can clearly see in the deviation map as a break in the vessels. So this can be artifactually seen as areas of thinning. And here, these dark areas, which is seen in the thickness map, indicates areas that have not been scanned by the machine. So again, there is loss of segmentation errors, which are clearly depicted by the horizontal as well as the vertical tomogram. Next is the floaters and vitreous opacities. So in this example, when the floater is lying outside the calculation circle, as I told earlier, the calculation circle is 3.4 mm. The RNFL thickness parameters are calculated within this particular calculation circle. So when the floater is lying outside the area of calculation circle, it is not being depicted in the clock hour map. While it comes into the calculation circle, it is being seen as an area of thinning. So same is being shown here in the thickness map and the deviation map because of the floater. So next is the segmentation errors. You have to see whether the proper segmentation is happening. Otherwise, artifactually, we can have areas of thinning. So apart from artifacts, we have to look at some anatomical variations also. So I actually told the hourglass pattern in the thickness map. That is how the normal OCT looks like in the thickness map. So in this picture, you can see an area of split. This is the split RNFL bundle, and this is seen as an area of thinning in the deviation map. So when you're looking at the TSNIT plot in this example, you can see a dip in the superior aspect. So this is a normal anatomical variation, which is usually seen in the superior quadrant. Next anatomical variation is the shifted peaks. This is commonly seen in case of myopes who has tilted disc. So here you can see the shifting of the peaks. Both the peaks are shifted temporarily. And this will be reflected as again as areas of thinning in the RNFL analysis. So I already talked a few examples of red disease. Now let us look at an example for a green disease. So in the first view, you can see this printout is looking absolutely normal. But if you have a closer look, here you can see a beautiful area of thinning which is clearly demarcated, which is represented in the thickness map and the deviation map, while the RNFL analysis completely misses out on this. And the fundus imaging also shows the area of RNFL thinning. So this is an example of green disease. And even in macular analysis, you should be aware of macular pathologies which can affect the analysis. Here is an example of ERM which has caused artifactual thickening of the maps. So another disadvantage of OCT in glaucoma, the RNFL thickness it cannot measure below 40 to 50 microns, which we call as a floor effect. So it is not useful in advanced glaucoma for monitoring purpose. So next parameter I would like to focus is the neuroretinal rim. So initially the Brooks membrane opening to the horizontal rim width was the parameter which we used to use commonly. But now the new parameter which has come up is the minimum rim width, which has found to be more specific and sensitive than the horizontal rim width. This is a printout obtained from a spectralis OCT which shows minimum rim width measurements in multiple quadrants. So again, this is color coded for ease of interpretation, the green indicating normal and the red indicating abnormal. Let's see an example how minimum rim width helped us. So she's a 40-year-old doctor who was referred as a case of glaucoma suspect with normal intraocular pressure, no family history. These were her fundus pictures. Again, this was a little bit doubtful in the superior area. But in this picture, you can see there is a mild tilt occurring. So the visual field revealed a normal printout. And we went ahead with the RNFL analysis. Here you can see some areas of thinning both in the right eye and the left eye. But again, if you look at the TSNIT plot, you can see a clear shifting of the peaks. So this might have affected the RNFL analysis. So we went ahead with the rim width analysis, which clearly showed the rim width to be normal. So this is one area where we can use the minimum rim width, especially in myopic patients. So again, like fundus photos, artificial intelligence has been incorporated in OCT, and maybe in future it will come up big. So to summarize, the topographic RNFL or GCIPL thickness analysis is more informative than the circumpapillary retinal nerve fiber layer analysis. The RNFL assessment is more sensitive, but the rim assessment is more specific for glaucoma. The wide field assessment of OCT, which includes the optic disc and macula, is recommended. So having said all that, why do we need to clinically examine the optic disc in the diagnostic evaluation of glaucoma? If only we see the OCT, we are going to miss out on the color configuration of the disc and all the non-glaucomatous optic neuropathy we were talking in the previous presentations. So this neuroretinal rim pallor was found to be 94% specific for non-glaucomatous optic neuropathy. I would like to highlight the part that even in glaucoma, whatever rim is remaining will always be pink. So let's have a glimpse into the OCT angiography. Madam covered the basics, so I'll be talking about the glaucoma point of view. So glaucoma has shown to reduce the perfusion at various levels of optic nerve head. So there are some parameters which we use in glaucoma. There is a flux index and the vessel density. And we scan two regions again, the optic nerve head as well as the macula. In the optic nerve head region, we have three slabs, the nerve head slab, the RPC slab, and the choroidal slab. For glaucoma point of view, we are going to use these two slabs, that is the RPC slab and the choroidal slab. So in the RPC slab, the vessels within the retinal nerve fiber layer are depicted. And in the choroidal slab, it delineates choroidal vessels in the parapapillary region. So these are the OCTA scanning regions in the macular region. There is a superficial slab and the deep slab, and studies have shown that superficial slab is better for glaucoma analysis. So these are the two key features which have been shown in the OCTA. There is a reduction in the peripapillary vessel density, especially in the RPC slab. So in this picture, you can see the RNFL thinning in the thickness map, deviation map, and the corresponding OCTA showing the reduction in the peripapillary vessel density in the same area. And again, in this case, this is a more advanced or moderate glaucoma. Here you can see the reduction in the peripapillary vessel density inferiorly. So next is the parapapillary microvascular dropout, or also called MVD. This is specially seen in the choroidal slab. So studies have shown that this is associated with thinner global RNFL, worse visual field mean defects, and higher incidence of disc hemorrhages. Essentially, this microvascular dropouts indicates progression. So having said all that, where does OCTA stand today? So when compared with OCTA and visual fields, it is clearly seen that OCTA changes occur before the visual field damages in glaucoma. But when compared to OCT, how is it performing? The diagnostic ability of OCT somehow is better than the OCTA, even in the peripapillary region as well as the macular region. But what is the advantage of OCTA is that the floor effect is reached later at a later stage than the OCT. So this indicates that this might be better in monitoring progression. But again, it has the same limitations as the OCT, which has motion artifacts, floater artifacts, etc. And also it has a higher test-retest variability when compared to OCT. So to summarize, OCTA may be a better tool to monitor progression, but it still needs to evolve before becoming part of a routine glaucoma workup. So a little bit of glimpse into the future upcoming imaging modalities. So there is something called the detection of apoptosing retinal cells, or the DARC. This again, you have the detection of the apoptosing retinal cells. The dying retinal cells are marked with the fluorescent biomarker. Initially in the phase 1 trial, the problem they were facing was they had to count these dying cells manually. But again, with the new player in the field, the AI, they have gone to the phase 2 trials with AI incorporated into the DARC. The next is the ROTA, or the retinal nerve fiber layer optical textural analysis. This has been derived from the SwepSource OCT. Here the RNFL optical texture is analyzed, and this has been known to detect before the OCT also. So this picture shows the fundus imaging, and it is not very much evident in the OCT picture, but you can see a clear-cut loss in the ROTA images. So this might be another exciting prospect in the future. So next is the adaptive optics. This was used in the field of astronomy. So here we were all counting the dying cells. Here the focus is on the normal retinal ganglion cells, RNFL cells, etc. Again, the first phase they were facing difficulty because they had to manually count the cells. With the AI in the field, they have started incorporating AI into adaptive optics. So to summarize, for glaucoma diagnosis, as far as OCT is concerned, the RNFL analysis, the neuroretinal rim, that is a minimum rim width, and GCIPL may be helpful, but one should not discount a good clinical examination. For monitoring, you should add the visual field progression into the loop. To conclude, the emergence of accurate, sensitive, and reproducible imaging modalities which is not replacing but complementing clinical judgment has revolutionized glaucoma management, and there are some lot of exciting prospects which are coming in the pipeline. I would like to end with this quote by Albert Einstein: as our circle of knowledge expands, so does the circumference of the darkness surrounding it, as the search for the unknown continues. Thank you.
Thank you, Dr. Madhavi, for the wonderful lecture. I would like to get comments from the glaucoma consultants on panel.
Madhavi has covered it really well, and the future of the investigations she has really covered well. And there is one question about the TME credit hours, Padma, that you need to answer. The question answer. Something is there's TNMC credit hours for the CME.
Do we have TNMC credit hours for the
Yeah, we have credit hours for this.
And they have also asked whether these presentations can be given online.
We have an observer from the TNMC who is also observing it. It is given.
Okay. Yeah.
No, two things. One, during registration, you are asked your TNMC number. So if you entered your name correctly and your TNMC number correctly, only then you'll get your TNMC credit hours. So that is one thing. And as far as the presentation being available online, all the webinars which are conducted by TNOA are hosted on the TNOA website. If you go to the section called webinars on the TNOA.info, you will find a tab called webinars. You will find every presidentship, each president's term, whatever webinars were conducted, you will find everything there. Not one has been missed. Yes. Of course, it will take a week or 2 weeks for this to get rehashed and then uploaded, but it will take a week or 2 weeks maximum. But you will find it there ultimately, if not immediately.
Okay. So your comments and inputs, RK sir.
No, other people are there. No? Yeah. Ravishankar, you didn't open your mouth.
Sir, I have no questions or comments because I did learn a lot in this presentation by Dr. Madhavi. Really excellent, really excellent. And of course, all the speakers for that matter, it was definitely a learning process, the entire webinar.
Definitely.
Thank you so much.
Yes. Thank you. Yeah, that's what I feel.
Thank you, sir.
It's good, really. It's a good session. Thank you, Madhavi.
Yes, sir.
Thank you, sir. Thank you, sir.
Okay,
I think we can close the session.
Yeah. Thank you, Madhavi. Thank you for coordinating the session very well. And this thing, no, I will ask our Secretary, Sriram Gopal, to give vote of thanks.
I'll make it very short, sir. Thank you to our dear President, Dr. Ramakrishnan, sir, for organizing the CME. I would like to thank the main moderators who help run this session very smoothly and swiftly, Dr. Padmavati and Dr. Madhavi. And special thanks to the esteemed panelists, which include Dr. RK sir, Ratna madam, Dr. Mahesh Shanmugam, Manju Pillai, and Ravi Shankar. And a big thanks to all the speakers, starting from my dear friend, Dr. Mahesh Kumar and Dr. Parag Shah and Vijay, and also Dr. Neetu Mohan, Dr. Vidya Rani, Dr. Vanila, and Dr. Kalavati. who take painstakingly prepared in detail, because this is something different. It is not a run-of-the-mill talk where you talk of just optic disc changes in glaucoma. Each topic was phrased in a different way. And I'm sure a lot of people who thought that this talk is on optic disc and RK sir is organizing this talk, they thought it will be predominantly glaucoma. But as a surprise, RK sir has designed it so that only the last talk concentrated on glaucoma. All the other talks have not hardly had anything about glaucoma. So we were all in for a very big, pleasant surprise, actually, a pleasant surprise. And a big thanks and shout out to the Arvind IT team who enabled this process. Sir, I was observing, apart from the panelists and office bearers who were around almost 20 in number, we had close to 225 participants in the webinar, which is a very, very big number. And yes, we did have some issues logging in. I think there's a learning curve to it. One good thing about this webinar, no, sir, but the plus side is, sir, if we have only the panelists on Zoom and others on YouTube and Facebook, we do not get this much of interaction. But in this webinar, because they were also on Zoom, we got a lot of questions. Almost every talk which was there were a few questions in the chat box. So the interaction is much more when all participants are on Zoom. The only problem is they cannot, there's a lot of muting and unmuting and stuff. But I think from next time onwards, it should just have it such that it should be like this, so that all of us are on Zoom, because Zoom can accommodate large numbers. So I think this is a very good format. Only thing, we should learn how to utilize this format better.
Thank you. Good.
And big thanks to everybody for sparing the Sunday morning. Thank you. Thank you so much.
Okay.
So one more question on Sriram, one more question on outside Tamil Nadu, how to get the credit hours is also there as a message.
Outside Tamil Nadu, I think is actually not available. What has to be done is, I think a certificate, if I'm not mistaken, a certificate needs to be issued by the TNOA saying that so-and-so attended this meeting, and that needs they have to submit it. As far as TNMC is concerned, it is automatic. If your number and name are correct, you'll automatically get the credit hours. But if it's outside Tamil Nadu, I think you have to issue a certificate and they will have to take it up with their own medical council. I will, if somebody has a query on that, you can just shoot an email to tnosecretary@gmail.com. I will find out how it should be done and get back to you. If you can't remember the email, you can go to TNOA website, you will find the email. You also find a WhatsApp number there. And that reminds me, I will maybe use this opportunity to reach out to people. I'm sure most of you are aware TNOA has got a WhatsApp number. Please add that number. Only then you'll get updates about meetings like this. You'll get the journal itself. All members of TNOA, you'll get the journal delivered to your phone. So please, I'm sure all of you all would have got messages. We've ensured we've sent individual messages to everybody. In case you don't get the message, go to the TNOA website. You'll find the WhatsApp number there. Send a WhatsApp message with your name and TNOA number. We will sort it out. And regarding CTNMC credit hours also, pick up the email from the web address and send me a mail. I will see what can be done. So I don't know, sir. There are very good attendance, sir. I think partly because we reached out to WhatsApp.
Okay, thank you. Thank you. And we have to thank our observer, Dr. Mohammed Ibrahim, for sitting throughout the session from morning 9:45 to 1:15, more than 3.5 hours. Thank you, Doctor. Thank you, Dr. Mohammed Ibrahim.